of half of the body is known as hemiplegia. And hemiplegia is a sign of anybody? Very good. Hemiplegia is a sign of CVA, that is cerebrovascular accidents, which can be of two types, as we have discussed in medicine. If it is lasting for less than 24 hours, the symptoms, then it is called as transient ischemic attack, TIA. If it is lasting, the symptoms are lasting for more than 24 hours, then it is called as stroke. It is of two types. Either it is a hemorrhagic stroke or an ischemic stroke. More common being the ischemic stroke. In ischemic also we have further two subtypes, that is either embolic or a thrombotic stroke. More common being the embolic stroke. Okay? So यहाँ पे hemiplegia was there for 8 hours. This is the most important thing in deciding the treatment. Why? Because the time from the symptom onset will decide which of the following treatment should be given to the patient. So this was the keyword for you. NCCD head is taken and it appears to be within normal limits. If it was hemorrhagic stroke, I hope all of you are quite aware. Hemorrhagic stroke means blood release hota hai, and whenever there is blood in the brain, that will appear white on a CT scan. Okay, so therefore, if it was a hemorrhagic stroke, there would have been a hyperdensity or a whitish opacity that would have been seen on CT. But यहाँ पे CT कैसा दिख रहा है? It appears to be within normal limits. And either the CT is in normal limits in cases of ischemic stroke, or sometimes it can show a hypodensity, that is blackening would be seen sometimes. Okay? But that blackening is not seen in all the cases. It is only seen in extensive stroke. Matlab, when a stroke like middle cerebral artery will occur, in that stroke this hypodensity is a common feature. Otherwise, hypodensity is usually seen after a few hours. Okay? That is the thing. So here the CT is occurring within normal limits. So it is a case of ischemic stroke. The blood pressure of this patient is 190 by 110 millimeters of Hg, which is the next step in this case. So if it is a ischemic stroke that we have come to a diagnosis, then what should be done for ischemic stroke? The usual treatment option for ischemic stroke is, without the time, just tell me the treatment of choice for ischemic stroke. So the treatment of choice for ischemic stroke should be thrombolysis, and thrombolysis is done with recombinant tissue plasminogen activators. And which are these recombinant tissue plasminogen activators? Drugs like altiplase, retiplase, tenecteplase, or streptokinase. Streptokinase is derived from your streptococcus. Okay, therefore definitely it has some allergic component to it. But all of these which are recombinant, that is altiplase, retiplase, and tenecteplase, these are actually synthesized ones, and therefore they have no allergy component or side effect related to it. Okay? So usually we use altiplase in cases of stroke. No issues with this, anybody? Altiplase or retiplase can even be used. Okay? And if they ask you the longest acting RTPA, then the answer would be sabse bada naam, tenecteplase. Okay, so please remember the longest acting thrombolytic agent if they ask you, or a recombinant tissue plasminogen activator, answer should be tenecteplase. So this is done definitely. Thrombolysis to break the thrombus, which is obstructing the blood flow to the brain. But please remember, in cases of thrombolysis, it is only effective if it is done within 4.5 hours of symptom onset. मतलब अगर patient को symptoms हो रहे हैं, उसके within 4.5 hours, if we do thrombolysis, then and then only it is effective. Okay, if the patient presents to you after 4.5 hours of symptom onset, then thrombolysis is absolutely contraindicated. Thrombolysis is not to be done in the patient. Okay, that is the first one. Second, the BP of this patient is also 190 by 110 usually. And who is a candidate for thrombolysis? The candidate for thrombolysis is a patient jiska BP hota less than 185 by 110. Okay, so the second contraindication for thrombolysis again is BP. Okay, if the BP was less than 185 by 110, we would have gone for thrombolysis, and the symptom onset should have been within 4.5 hours. यहाँ पे सबसे important find it is the symptom onset. Symptom onset होके कितना time हो चुका है? 8 hours. And secondly, so that is thrombolysis is absolutely contraindicated. Okay, and the BP is also high. So here, if even the patient would have presented to me within 3 hours of symptom onset, for example, ठीक है, और BP अगर इतना होता, the first management would have been to lower the blood pressure, and then I would have gone for thrombolysis. No issues with this. अभी यहाँ पे the symptom onset has surpassed the limit, that is 4.5 hours. So here we will only go for observation and monitoring of the patient, and that is the thing that you need to remember. ठीक है? So pharma का question हमेशा drugs ही आंसर नहीं हो सकता, ये बताने के लिए क्वेश्चन था. ठीक है? So it is observation and monitoring. After 4.5 hours of symptom onset of the patient presents to you, then the answer should be observation and monitoring. Reason being, तुम बोलोगे BP control क्यों नहीं कर रहे हैं? BP is controlled usually when we need to do a thrombolysis in this patient. Otherwise, usually BP can be usually the BP है ना 220 systolic and 140 usually 120 usually diastolic तक हम bear कर सकते हैं. Why? Because if the blood pressure of this patient is high, then there would be increased cerebral blood flow. Already cerebral blood flow कम हो गया है. So if the blood pressure of this patient is high, at least some of the blood will flow to the brain, and therefore the BP is never decreased if it is not very much high. Okay, it is only maintained at a basic level. And यहाँ पे BP is not exceeding 220 by 120. Therefore, we will not control the BP as a primary measure. No issues with this, anybody? If the BP was exceeding 220, then definitely here our main treatment would have been giving IV Levetolol to this patient, or IV Nicardipine is generally used in case of strokes. No issues with this, anybody? That is the thing. And in hemorrhagic strokes, the drug which is given to control, it is called as IV Nicardipine. Okay, IV Nicardipine. And IV Nicardipine is a which group of drug? Calcium channel blockers. Which calcium channels are blocked? T or L type? It blocks T calcium channel blockers because these transient or the short acting calcium channel blockers are present in the CNS. Okay, and Nicardipine is usually cerebroselective. That means it only acts on these T calcium channels which are located inside the CNS, and therefore Nicardipine is mainly limited for use only in cases of hemorrhagic stroke. Otherwise, Nicardipine ज़्यादा तुम बाहर नहीं देखते हो. You usually use in cases of intracerebral hemorrhage. No issues with this, anybody? That is the thing. Got it? ठीक है. So अगर if the patient presented to me within 4.5 hours of symptom onset in case of ischemic stroke, then my answer would be thrombolysis, that is recombinant tissue plasminogen activator. ठीक है? If the limit, that is 4.5 hours of limit is exceeded, the time limit is exceeded, then I will go for observation and monitoring. Here it has surpassed. Here the patient is presented to you after 8 hours of symptom onset. Therefore, you will go for observation and monitoring. ठीक है? BP is only controlled in conditions where you need to do a thrombolysis and BP is more than 185 or 110. And secondly, if you don't need to do a thrombolysis, then you can observe the patient till the BP exceeds 220 by 120. कोई दिक्कत नहीं है इसमें. If no thrombolysis is to be done, blood pressure can be monitored till 220. But if thrombolysis is to be done, then we need to decrease as soon as it exceeds 185 by 110. No issues with anybody? So when I repeat, जब तुम्हारा हो जाएगा, जब मैं कार्डियो रिपीट करूंगा तो उसमें और ढंग से हो जाए. कोई दिक्कत नहीं है इसमें. एटलीस्ट ये बात याद रखो. Moving further, question number 2 now. A 30-year-old male patient presented to the emergency of your hospital with a history of poisoning with an unknown seed. So you don't know the poison which he has consumed. On examination, the patient is delirious. The pupils are dilated. Pupils dilated matlab mydriasis. ठीक है? And there is decreased salivation that causes dry mouth usually in this patient. So all the D's: delirium, dry mouth, mydriasis. Which of the following drug is used for this condition? Which is the poison, first of all? Very good. The poison that you are suspecting, unknown seed. Please remember, this is more likely talking about a dhatura poisoning. Okay, it is more likely talking about a dhatura poisoning, which resembles atropine poisoning. No issues with this. The symptoms of atropine and dhatura poisoning are similar. All of them usually will lead to sympathetic system or anticholinergic symptoms. बोल सकते हो. Something like dry mouth, delirium, dilated pupils. Okay. Apart from that, the patient might have sometimes increased respiratory rate as well. कोई दिक्कत नहीं है इसमें. That is the thing. Now here, as we have diagnosed, it is dhatura poisoning. What should be the drug for dhatura poisoning? Anybody? So if it is an anticholinergic poisoning, something like dhatura poisoning, we need to give a cholinergic drug. And the cholinergic drug which is given to this patient is a soluble agent. Why we will give a soluble agent and not a non-soluble agent? Soluble कौन सा? Lipid या water soluble? We will give a lipid soluble agent. Why? Because we need an agent which can cross the blood-brain barrier, okay, to decrease the CNS symptom in this patient, okay. So only a lipid soluble agent will be able to cross the blood-brain barrier, which is made up of lipids, and therefore the CNS symptoms of the patient can be controlled. And the lipid soluble agent out of neostigmin and physostigmin as we have, it is always physostigmin which is given. No issues with this. SO for soluble, N for non-soluble. No issues with this, anybody? So that is to be remembered. Please remember this. Atropine is rather absolutely contraindicated because atropine and dhatura has similar actions. Agar atropine de doge patient ko, that will lead to worsening of the symptoms, not improvement in the symptoms of the patient. No issues to anybody. And pilocarpine is not a cholinergic agent which will act on all the cholinergic receptors. Rather, it is selectively acts only at the M3 receptors. Very good. It selectively acts only at the M3 receptors, which that too only in the pupils. And therefore, if it stimulates this M3 receptors in the pupils, it will cause meiosis. It will only lead to meiosis. So only one symptom can be improved with pilocarpine, that is mydriasis. Usme improvement hogi bas, not the other CNS symptoms or the other symptoms or the secretory symptoms of the patient would be improved with pilocarpine. ठीक है? And meiosis pilocarpine kaha use karte ho, which is the M3 agonist. Very good. It is used in cases of glaucoma. Which glaucoma? Angle closure or open angle? Very good. It is used in cases of angle closure glaucoma. And in which conditions of angle closure glaucoma? Maintenance or acute attack? Acute attack of glaucoma. ठीक है? So pilocarpine is the drug of choice for acute attack of glaucoma. Why? Because it breaks the attack. Okay? Why not mannitol? Because mannitol will definitely decrease the intraocular pressure. Please remember, it is the first drug to be given along with tablet glycerol and tablet acetazolamide. Okay, these are the first drugs to be given. But in cases of acute attack, the main complaint of the patient is pain. Okay, the main complaint of the patient is pain that is due to spasm of your ciliary muscles. So the main important aim is to relieve the pain of the patient by breaking the attack. And as it causes meiosis, the attack would be broken. And therefore, in cases of acute attack of glaucoma, acute attack of angle closure glaucoma, answer should be pilocarpine. But for maintenance, if they only write angle closure glaucoma, then the drug of choice can be mannitol. कोई दिक्कत नहीं है. So drug of choice for angle closure glaucoma, mannitol. But drug of choice for acute attack of angle closure glaucoma, pilocarpine. No issues till here, anybody? So that is to be remembered. Neostigmin, I hope all of you are quite aware. Neostigmin, as I discussed, it is a non-soluble cholinergic drug, whereas physostigmin is a soluble cholinergic drug. The longest acting cholinergic drug out of these. Among this, we also have one more drug which is the longest acting, that is called as pyridostigmin. Okay, the another drug which is longest acting is known as pyridostigmin. And what is the indication of pyridostigmin? Where it is used? Very good. Myasthenia gravis mein, the drug of choice is pyridostigmin because it is the longest acting drug. No issues with this, anybody? So physostigmin is used for two poisonings. First that we discussed, physostigmin is used for dhatura poisoning, and second, similar action was also caused by atropine. So in case of atropine toxicity or atropine poisoning also, the drug of choice will remain same, that is physostigmin. Even in cases like atropine is derived from a plant known as Atropa belladonna. So even if they say the poisoning is due to Atropa belladonna, your answer should remain same. That is again physostigmin. So physostigmin is the drug of choice in three conditions. First is which poisoning? Dhatura poisoning. Which toxicity? Atropine toxicity. And last, which poisoning? Atropa belladonna poisoning. No issues here. Whereas neostigmin, if I talk about, important about neostigmin, please remember, this neostigmin, usually, it is used in which condition? It is very good. It is used in cobra bite mainly. Please remember, why cobra bite? Because cobra is a neurotoxic snake. Okay, it is a neurotoxic snake and it mainly acts on which receptor? It mainly acts on the NN receptors, that is the nicotinic neuronal type of receptors which are located inside the ganglia. Okay, so that it mainly acts on the NN type of receptors. It stimulates this NN type of receptors and reverses the paralysis of muscles caused by cobra bite. No issues with this, anybody? That is the first indication. Second, it is also used for reversal of, very good, it is also used for the reversal of muscle relaxants. It is also used for the reversal of muscle relaxants. So usually before surgery, we use muscle relaxants, depolarizing muscle relaxants like succinyl choline, or non-depolarizing muscle relaxants like atracurium, pancuronium, D-tubocurarine, though not used nowadays, but all of these agents. Okay, I hope we have discussed this in anesthesia. So these are used for muscle relaxation. For reversal of this agent, usually we use neostigmin. But whatever is the problem, neostigmin definitely can reverse their action inside the CNS. Okay, outside the CNS in the ganglia, but it will not reverse their action. Important, it will not reverse their action of cholinergic side effects. Okay, please remember, neostigmin can reverse their action at the level of the neuronal receptors, that is NN receptors. But the side effects which would be caused by neostigmin at various other receptors, that is your muscarinic receptors, they can lead to problem in the patient. Okay, and therefore to stop this action of neostigmin and the other receptors, the peripheral side effects which it will lead to, like it will cause increase in secretions. Okay, it can cause meiosis, it can cause bronchoconstriction. So all of these actions are due to this agonistic activity at the muscarinic receptors. Therefore, to block this activity or to block this peripheral side effects of neostigmin, along with neostigmin, we always give atropine. Always we give atropine. And why atropine is given? To block the muscarinic activity. To block the muscarinic activity of neostigmin. Please remember. Why? Because atropine is a muscarinic blocker or a muscarinic antagonist. Okay? So whether in cobra bite or in cases of reversal of muscle relaxation, always give neostigmin along with atropine. No issues with this, anybody? That is the clear one. Moving further, shall I? Question number 3 now. An elderly 65-year-old male patient presented with tremors, slowness in the movements, and expressionless faces. That is a characteristic clinical feature of stoop posture and is taking short shuffling steps. This short shuffling step is called as which type of gait? This is what is known as the fascinating gait. Okay, and this expressionless faces is also known as mask-like faces. It is also known as mask-like faces. Okay, slowness of movements is nothing but bradykinesia. So tremors, bradykinesia, mask-like faces, fascinating gait, and stoop posture. This is a characteristic picture of Parkinsonism in a patient. Okay, and if the patient is suffering from Parkinsonism, which among the following drug can be used in this patient? So donepezil, we know it is the drug of choice for Alzheimer's disease. It is a cholinergic drug and therefore used in cases of Alzheimer's disease. Rivastigmine and galantamine are also the drugs which are used in cases of Alzheimer's disease. Even one more drug that we use in Alzheimer's is called as memantine. But rasagiline is a drug which can be used in cases of Parkinsonism. Okay, rasagiline or the other drug in this group is selegiline. And this rasagiline and selegiline, what is their mechanism of action? MAO A or MAO B? Very good. They are selective MAO B blockers or they are selective MAO B inhibitors. Okay, that is the funda. So monoamine oxidase type B, it is present inside the CNS and they will selectively block this monoamine oxidase B. Okay, they are selective to this MAO B. But if they ask you what is the drug of choice for Parkinsonism, if you need to give a single best answer, very good. So it is nothing but the D1 or D2 agonism. It is D2 agonist, something like pramipexole or ropinirole. Please remember, these are drugs like pramipexole or ropinirole. No issues with this. For younger patients of Parkinsonism, usually the drug of choice are pramipexole and ropinirole. But if it is an elderly patient, we can use the most effective drug for Parkinsonism. And the most effective drug for Parkinsonism is definitely levodopa. And which combination? Carbidopa. Okay, so levodopa, carbidopa combination. But they are not given alone. They are also given with one another drug that is called as a COMT inhibitor, catechol orthomethyl transferase inhibitor. And ये जो COMT inhibitor is combination के साथ add करी जाती है, that is what is called as entacapone. Please remember that drug is known as entacapone usually. Okay? So this combination is usually used in elderly patients. Otherwise, the drug of choice in younger patients of Parkinsonism, answer should be pramipexole or ropinirole. Most effective drug, again levodopa should be your answer. No issues to anybody? Apart from that, we have discussed already in psychiatry, this in case of Parkinsonism, even we can do deep brain stimulation. Okay, if there is a suicidal risk, even we can go for a deep brain stimulation in this patient. No issues to anybody? So, These are the important things you need to remember. And even an antiviral drug. This was a previous year question. Antiviral drug which is used in cases of Parkinsonism. Answer is amantadine, which is used for influenza. So this amantadine is an antiviral drug used in cases of Parkinsonism. ठीक है? Alzheimer's के drug कौन से थे? Drug of choice was donepezil. The other drugs were rivastigmine, galantamine, and memantine. Parkinsonism के लिए the drug of choice in younger patients were pramipexole or ropinirole. In elderly it was levodopa, carbidopa along with entacapone. Okay, antiviral drug use was amantadine. MAO B inhibitors use were rasagiline and selegiline. No issues. So this is all about your Alzheimer's and Parkinsonism. Question number 4 की अगर मैं बात करूं, parents of one child were called by the principal to the school and during interaction they were told that your child is not normal like others as he is very hyperactive in some of the situation and not being attentive in class. Drug of choice for the treatment of this child is, first of all, what is the provisional diagnosis? Answer is ADHD, that is attention deficit hyperactivity or hyperkinetic disorder. Okay, so here the child will be very inattentive in class. He would be roaming and there disturbing other students. Okay, and the child will also have hyperactivity. Okay, so inattention and hyperactivity are characteristic features of ADHD in children. And what is the drug of choice for ADHD? Answer is only one, that is methylphenidate. No issues with this. Okay, so methylphenidate is the drug of choice for ADHD. Whereas the other drug that we use in cases, it is a CNS stimulant. This CNS stimulant, that is modafinil. This modafinil is the drug of choice in which condition? Very good. It is the drug of choice in cases of narcolepsy, where the patient will get recurrent sleep attacks. Okay, to prevent the sleep attack, we need to stimulate the CNS, and therefore we give a CNS stimulant like modafinil. Okay, even amphetamines are considered to be CNS stimulant, and one of the amphetamines is methylphenidate. No issues with this, anybody? That is the thing. Okay, atomoxetine वगैरह can be used, but the drug of choice only is one, that is methylphenidate. Other drugs can be used. Shall I move further? If I talk about question number 5 now, a young male patient was experiencing auditory hallucinations and delusions. Hallucinations and delusions are a characteristic feature of which type of disorder? Psychotic or neurotic? Psychotic disorders. And there was also thought withdrawal symptoms in the patient. Thought withdrawal symptom मतलब कोई मेरे दिमाग से मेरा thought चुरा रहा है. That is what is thought withdrawal symptom. The psychiatrist was planning to start the patient on antipsychotics. What do you think would be a provisional diagnosis in this patient? Very good. So psychotic symptoms like hallucination and delusions. That to which type of hallucinations mainly? Auditory hallucinations, which are commonest type in psychotic disorders. And thought withdrawal symptoms in a younger male, that is more likely to suggest your schizophrenia. Okay. And in the schizophrenia, the psychiatrist was planning to start antipsychotics. Which among the following drug is least likely to develop extrapyramidal side effects? Now, if I talk about schizophrenia, schizophrenia is due to increased levels of which of the following amines, monoamines? Very good. It is due to increased levels of dopamine. The patient starts having psychotic symptoms. Okay. Even sometimes they also consider there would be increased levels of another monoamine, serotonin. This is also implicated as a cause in cases of any psychiatric disorder. Therefore, our main aim should be what? To decrease the levels of dopamine and to decrease the levels of serotonin in this patient. And therefore, we will give usually antipsychotic drugs which will actually decrease the levels of dopamine and serotonin. So, based on that, we have two types of antipsychotics. One are typical and second are atypical antipsychotics. Typical antipsychotics mainly acts. I'm saying C. Antipsychotics can be antagonists to dopamine as well as to serotonin receptors. But mainly if I talk about more, किस पे काम करते हैं? So typical antipsychotics mainly cause D2 antagonism. Typical antipsychotics mainly cause D2 antagonism. Whereas atypical antipsychotics mainly cause 5-HT2 antagonism. That way it will mainly block serotonin receptors usually. No issues with this. That is why we call them typical and atypical antipsychotics. Now, can anybody tell if dopamine is decreasing, therefore the patient starts having extrapyramidal side effects? Yes. If the dopamine decreases a lot, then definitely the patient can even develop Parkinsonism-like feature. And this one, it is due to some other drug. Therefore, it is called as drug-induced Parkinsonism. Okay, that is the first symptom. Second, the patient will also develop extrapyramidal side effects. These are nothing but movement disorders. Okay? And these extrapyramidal side effects are mainly due to deficiency of dopamine inside body, and therefore they are commonly associated with which ones? Typical antipsychotics. Okay? So the most important side effects of typical antipsychotics are these extrapyramidal symptoms or these extrapyramidal side effects. If they ask you which is the most common extrapyramidal side effect, answer should be very good. It is acute akathisia. Please remember the most common. If I ask you, the answer is acute akathisia. But if I ask you the earliest one, अब तुम्हारा answer सही है, then your answer would be acute dystonia. Please remember. Okay, so the most common extrapyramidal side effect associated with typical antipsychotics, answer is acute akathisia. When the patient would be absolutely restless, will keep on walking throughout the room. Okay, and second side effect is acute dystonia, when it is due to spasm of a particular group of muscles. So if, for example, the sternocleidomastoid or neck muscles go undergo spasm, the patient will have torticollis. If the pterygoid muscles undergo spasm, the patient will have trismus or lockjaw. So all of these features would be seen with acute dystonia. A long-term side effect of these antipsychotics, mainly it is due to withdrawal of these antipsychotics rather, that is called as tardive dyskinesia. Okay, that is what is known as tardive. Tardive means long-term. Okay, that is known as tardive dyskinesia. Whereas if the dopamine levels falls really very low, the patient starts developing bradykinesia, tremors, and Parkinsonism-like features, all of those. That is what is known as drug-induced Parkinsonism. Okay, and the last important side effect that they develop is neuroleptic malignant syndrome. Okay, so these are the important side effects of typical antipsychotic drugs. Now, please tell me what is the drug of choice for acute akathisia? Very good. For the drug of choice for acute akathisia is a non-selective beta blocker like propranolol. It is also the drug of choice for essential tremors. So याद रखना, restless leg syndrome, acute akathisia or essential tremors. The answer, the drug of choice should be propranolol. Whereas for acute dystonia, what is the drug of choice? It is a cholinergic drug, something like benzhexol, also known as trihexyphenidyl. Okay, so anticholinergic drug like benzhexol or trihexyphenidyl is the drug of choice for acute dystonia. This benzhexol is also the drug of choice for drug-induced Parkinsonism. So if they ask you the drug-induced Parkinsonism के लिए drug of choice क्या है, answer should be benzhexol. Another name याद रख लो, in options sometimes they will not give benzhexol. Another name should be trihexyphenidyl. No issues with anybody? If they ask you what is the drug of choice for neuroleptic malignant syndrome, it acts mainly on which receptors? Ryanodine receptors, and that is the drug is what is called as dantrolene. Okay, and in tardive dyskinesia, अगर वो पूछेंगे what is the drug of choice? Very good. The answer should be tetrabenazine or valbenazine. ठीक है, tetra or valbenazine. Tetrabenazine is also the drug of choice in case of trinucleotide repeat expansion, gag repeats. Huntington's chorea. Tetrabenazine is also the drug of choice in case of Huntington's chorea. No issues with this, anybody? So these are all the extrapyramidal side effects of your typical antipsychotics. Atypical antipsychotics can also cause extrapyramidal side effects, but the incidence is very, very, very low. Okay, mainly atypical antipsychotics, they will mainly lead to which side effect? Endocrinal or metabolic side effects. Okay, they will cause lipodystrophy syndrome. Okay, they will cause lipodystrophy syndrome. They will lead to obesity. They will increase the insulin resistance in the patient. They will cause hyperglycemia in the patient. No issues with this. That together is known as the lipodystrophy syndrome. तो अगर मैं पूछूं lipodystrophy syndrome की risk किसमें ज्यादा है, answer should be atypical antipsychotics. और अगर मैं पूछूं movement disorders की risk किसमें ज्यादा है, answer should be typical antipsychotics. No issues with anybody. So here the patient has developed extrapyramidal side effects. Which is the following drug which is least likely now? Least likely. तो याद रखना, the drugs which are strong D2 agonists. The drugs which are strong D2 agonists will have the highest chance to develop extrapyramidal side effects. Some drugs like haloperidol, it is the strongest agent and therefore it has the highest chance to develop extrapyramidal side effects. Another drug with the same name, that is droperidol, it is also a strong D2 agonist. Or even one more drug, that is flumephenazine. These three drugs have the highest chances to develop extrapyramidal side effects. No issues with anybody? Now, if they ask you So please remember, among these following drugs, which among the following has the least chances? So it should not be any typical antipsychotic. Rather, it should be a atypical antipsychotic. So which among the following is the atypical antipsychotic? Answer is only one, that is clozapine. So out of all these drugs, clozapine has the least chances of developing extrapyramidal side effect because it is not a typical, rather a atypical antipsychotic. Okay. And if they ask you, among the typical antipsychotics, which of the following drugs has least chances of developing EPS? Among the typical ones, it is thioridazine because it is a weak D2 antagonist. Okay. Among typical, thioridazine. Overall, any atypical antipsychotic just like clozapine. No issues with anybody? EPS are seen with typical antipsychotics. Highest chances of EPS are seen with strong typical antipsychotics like haloperidol, and least chances among typical are seen with a drug like thioridazine. Okay, EPS के chances कम होंगे if we are using atypical antipsychotics. उसमें भी it would be least likely be seen with clozapine. Okay, highest chances among the atypical ones. Highest chances among the atypical ones for extrapyramidal side effects could be seen with a drug known as risperidone. Okay, याद रखना EPS mainly हो रहे typical के साथ, but अगर atypical के साथ हो रहे हैं तो याद रखना highest chances would be seen with risperidone. Zoom out किया यार, ठीक है? No issues with anybody. So these are the important things you need to remember about your antipsychotic drugs. Important is about clozapine. Now this clozapine can lead to some of the dangerous side effects or lethal side effects. ठीक है? One of the dose independent side effects which can occur at any dose is agranulocytosis. That is important side effect known as agranulocytosis. Therefore, clozapine is not given to the patient. Okay? So better I'll write it. Okay, so please remember that clozapine, it is a typical or atypical? It is a atypical antipsychotic and least chances of extrapyramidal side effects therefore. Okay? Here the major side effect that you need to remember is agranulocytosis, and therefore it is not given when the absolute neutrophil count is less than 1500 or the differential leukocyte count is less than 3500. No issues with this. ये ANC की बात चली, DLC अगर पढ़ा होगा तो it is less than 3500. कोई दिक्कत नहीं है इसमें. Apart from that, please remember it also leads to a dose dependent side effects which only occurs at high doses, and that is seizures can also occur. And third important, it can also lead to myocarditis. ठीक है? No issues till here. And clozapine is the atypical antipsychotic which has maximum chances of weight gain and sedation. So if they ask you among the atypical antipsychotic, maximum chances of weight gain and sedation are seen with, answer should be clozapine. कोई दिक्कत नहीं है. And highest chances of extrapyramidal side effects among atypical. अब बता दिया था मैंने आंसर. Answer was risperidone. No issues with anybody? समझ गए? वापस एक बार आएंगे इसी पे. Question number 6 now. A young female patient was a known case of migraine. She takes naproxen. Naproxen is which drug, anybody? NSAID. It is a non-steroidal anti-inflammatory drug. And these NSAIDs are the drug of choice for acute migraine. NSAIDs are the drug of choice for acute migraine, acute attacks of migraine. Okay? When they are mild to moderate usually. In severe acute attack of migraine, NSAIDs would be of no use. कोई काम नहीं करेगा NSAID for inpatients पे, ठीक है? So for acute exacerbation, she was taking naproxen, that is NSAID, on a regular basis. Now she started experiencing epigastric pain and hematemesis. So due to a prolonged use or due to a constant use of a drug like NSAID, she has developed epigastric pain and blood and vomiting, that is hematemesis. That is likely suggestive of which condition? Peptic ulcer disease. On prolonged use of NSAIDs, the patient will develop PUD, that is peptic ulcer disease, and that causes bleeding as well. Which is the best drug to be used in this condition? If you need to remember, drug of choice for any type of PUD. Answer remains same, that are proton pump inhibitors. Drugs like prazole, omeprazole, esomeprazole, all of these drugs. Okay, lansoprazole, pantoprazole, all of these. Okay? So PPIs, proton pump inhibitors, are the best drug or the drug of choice for PUD of any reason. But so therefore your answer would be, if I'm asking about the best drug, answer should be PPI. But if I say which is the most specific drug, which is the most specific drug for an NSAID induced PUD, which is the most specific drug for an NSAID induced PUD. So NSAIDs usually क्या करते हैं? NSAIDs block the prostaglandins. NSAIDs block the prostaglandins, and that leads to formation of peptic ulcers in the patient. Therefore, हम क्या देंगे? Prostaglandin analogs देंगे बाहर से. So if they ask you the most specific drug for NSAID induced PUD, answer should be prostaglandin analogs. Drugs like prostaglandin even analog, mesoprostol should be given. No issues with this. That is the thing. ठीक है? कोई दिक्कत नहीं है. मोस्ट स्पेसिफिक ड्रग में ही तुम्हारा आंसर बस रहेगा प्रोस्टाग्लैंडिन एनालॉग्स. अदरवाइज ऑलवेज आंसर इज PPIs, proton pump inhibitors. H2 receptor antagonists जो पहले दिए जाते थे, these were drugs like cimetidine, ranitidine, but nowadays they are ranitidine is banned, बाकी दे सकते हो, but the problem is they are not commonly used nowadays. ठीक है? PPIs are better drugs to be given. Okay, and antacids are usually the aluminium hydroxide or magnesium hydroxide like drugs, and antacids are the anybody क्या important punchline है? So the fastest acting, okay, fastest acting drugs for PUD अगर वो पूछेंगे, answer is antacids. No issues with this. They will neutralize the acid which is already formed inside the stomach, and therefore the fastest acting are the antacids which are given. Okay, no issues with anybody. But antacids, please remember, these antacids should not be combined with other drug. Very good. This antacid should not be combined with other drug, that is called as sucralfate, because this sucralfate will do what? That will do a coating of the ulcer. Okay, the sucralfate is responsible for coating of the ulcers. And अगर तुम antacids दे देते हो तो क्या हो जाएगा? Antacids will neutralize the acid, and the sucralfate usually works in an acidic environment. Therefore, if you give antacids prior to sucralfate, the patient will have no use of the sucralfate. No issues to anybody, because the sucralfate cannot act if the acid has been neutralized. ठीक है? So ये याद रखना important चीज़ है. Drug induced PUD है ना, NSAID induced PUD है. But for any reason, I have told you, for any reason of PUD, answer is same, PPI. If they ask you most specific drug कौन सी है, best drug is nothing but drug of choice ना. ठीक है? तो वो अलग तरीके से पूछा बस मैंने. I have just asked you best drug. Drug of choice ही होता है वो भी. Most specific drug अगर पूछा होता जो exactly उसी action को reverse कर देगा, then your answer would have been prostaglandin analogs. ठीक है? तो ये दोनों बहुत close terms है, ये हमेशा याद रखना. Either they will give the best drug, they will give drug of choice. Okay, अगर उनको पूछना होगा prostaglandin analog के बारे में, they will always mention most specific drug. Okay, or the action or the drug which will reverse the action. ऐसा कुछ वो पूछेंगे. ठीक है? That is the thing. Moving further, question number 7 now. A pregnant female was diagnosed with hyperthyroidism. If she is diagnosed with hyperthyroidism, she will have symptoms like she will be a very thin female due to increased basal metabolic rate. She will have heat intolerance as well. ठीक है? So she is having hyperthyroidism. She was started on an anti-thyroid drug. Drug of choice for hyperthyroidism are nothing but the anti-thyroid drugs, and these anti-thyroid drugs are 3. First is carbimazole. Second is carbimazole is an inactive form or a prodrug which is converted to its active form, that is methimazole. And last one is PTU, that is your propyl thiouracil. All of these 3 are anti-thyroid drugs. Okay, they will inhibit which enzyme? Anybody? Thyroid peroxidase. Okay, that is a rate limiting enzyme of thyroid hormone synthesis. So all of these are thyroid peroxidase inhibitors. Okay, therefore they are the most effective drugs in case of hyperthyroidism. Okay, now the child delivered was suffering from choanal atresia. They are saying choanal atresia is a congenital anomaly, and it can be due to intake of some of this drug. Which is the likely drug responsible for this? So the anti-thyroid drugs like carbimazole or methimazole, these are usually contraindicated in the first trimester of pregnancy because they can lead to teratogenic side effects. First, as you discussed, अभी ENT हुआ तुम्हारा, तुम्हें पता है choanal atresia. The child will be born blue and turn pink on crying. Along with that, choanal atresia, the other side effects which can be associated is cutis aplasia. That is, the skin of this child will not be properly form. So if this mention either cutis aplasia, पहला question जो आ चुका है, that was about cutis aplasia. I have just changed the other side effect, that was choanal atresia. So both of these side effects are commonly associated with antithyroid drugs known as carbimazole or methimazole. Therefore, here the answer would be option D, carbimazole. Therefore, if they say what is the drug of choice, if they ask what is the drug of choice for hyperthyroidism in pregnancy, okay, if I only mention hyperthyroidism in pregnancy, your answer would be propylthiouracil because it is the safest antithyroid drug. If I mention the drug of choice for hyperthyroidism in the first trimester of pregnancy, answer would again be PTO because during first trimester there is organogenesis which goes on. But if I mention the drug of choice for second and third trimester of pregnancy, you will change to again the most effective antithyroid drugs. Answer would be carbi or methimazole. No issues with this, anybody? That is the thing. Okay? And if I talk about, we have discussed this in ops, right? Gynae ops में discuss किया था. A patient of hypothyroidism during pregnancy, drug of choice क्या होगा? During pregnancy or even without pregnancy, also the drug of choice remains same. That is L-thyroxine. ठीक है? No issue with this. इसको L-troxin भी बोला जाता है. ठीक है? And we will gradually increase the dose of this L-troxin. Okay, please remember this. L-troxin या levothyroxine का gradually dose increase करना पड़ता है from 25 to 50 to 80 to 100. Okay, we will do not exceed 100 micrograms usually. ठीक है? That is the funda. And which drug is absolutely contraindicated during pregnancy? Answer is a radioactive iodine that is absolutely contraindicated in any trimester of pregnancy. Please remember this. And what is the radioactive iodine used for treatment? Iodine 131. Half-life be 8 days. And the other was iodine. The one used for diagnosis is iodine 125. No issues with this. 123 भी use कर सकते हो, 125 भी use कर सकते हो. ठीक है? No issues with anybody. So these are used for diagnostic purposes and half-life of these would be 13 hours. ठीक है? इसकी 8 days होगी, इसकी 13 hours होती है. इस बार क्वेश्चन था in case of prostate cancer radioactive iodine is used. Okay, and it is used for brachytherapy. So वो वाला कौन सा होता है? So please remember that is iodine 125. Okay. So treatment of prostate cancer में अगर brachytherapy के लिए use करना है, then it is iodine 125. No issues with this. This is a recent question of FMG June 2022. So वहाँ पे they did not mention thyroid cancer. If they would have mentioned thyroid cancer, my answer would have remained same. Iodine 131 is used for treatment, but that is only for thyroid cancer. They rather ask about prostate cancer की brachytherapy के लिए क्या use करेंगे? Then your answer will change to iodine 125. Otherwise, iodine 125 and 123 are always and always diagnostic in nature, except this one indication. No issues with this, anybody? ठीक है, तो याद रखो ये बात. And propylthiouracil along with prednisolone and propanolol, all these 3 P's. Okay, propylthiouracil, prednisolone and the propanolol. These 3 P's will inhibit the conversion of T4 to T3, and this is what is called as peripheral conversion. If they ask you peripheral conversion is inhibited by which 3 drugs, answer should be all the 3 P's. Propylthiouracil, a steroid like prednisolone, and a beta blocker like propanolol. These will inhibit the peripheral conversion. That is also helpful in case of hyperthyroidism. Why? Because T4 is an inactive form, whereas T3 is a more active form of thyroid hormone. So जब conversion होगा, तभी activity होगी. No issues with this, anybody? Question number 8 now. Which among the following statement is true about the given dose response curve? What is the usual shape? आने दो मेरे को. What is the usual shape of the dose response curve? Did I mention log dose response curve? So please remember the dose response curve का shape होता है usually rectangular hyperbola या hyperbola बोल लो. ठीक है? It is hyperbola. But if I mention log DRC, the shape of a log DRC would be sigmoidal shape or it would be S shape. No issues with this, anybody? And this log DRC is important. Why? Because it will tell us about 3 important effects of the drug. First of all, it can tell you about the efficacy of the drug. Efficacy मतलब वो drug कितनी काम कर रही है. Second one is potency of the drug. Potency is nothing but the power of the drug. ऐसे याद रख सकते हो. मतलब क्या कि कम से कम डोज में ज्यादा से ज्यादा इफेक्ट कैसे आ सकता है. That is what is potency. With minimum dosage, maximum effect can be achieved. That is what is potency. And the third thing that it will tell you about is the safety of the drug or the therapeutic index, you can say. Okay, it tells you about the safety profile of the drug. Okay, and safety is told by the slope. Okay, safety is told by the slope. मतलब अगर drug का ज़्यादा slope है, if the drug has a steeper slope, if a drug has a steeper slope like this, then the drug is safe or unsafe? Then the drug is unsafe. Whereas if the drug has a flatter slope, something like this, then the drug is safe. Then the drug is safe. No issues with this, anybody? Because from therapeutic to toxic effects, जो escalation होगा, if it is rapid, then it will lead to a steep slope, and therefore the drug is unsafe. And if from therapeutic to toxic effects, the escalation is very slower, then it will lead to a flat curve, and therefore it is a safer drug. So unsafe drugs, something like your sedative. Unsafe drugs कौन से होंगे? Barbiturate. And safer drugs would be your benzodiazepines. Lithium is also an unsafe drug. No issues with this because it has very narrow therapeutic index. Next, if I talk about power or the potency of a drug, this potency is actually told by the side of the graph. Okay, it is told by the side of the graph. If the graph is more towards the negative side, or if it is more towards the left side, that means the drug is more potent. Okay, if the graph is more towards left side, that means the drug is more potent. And as the graph shifts to left side, that means the drug is less potent. ठीक है? तो जो सबसे right वाला graph है, it is the least potent drug, and जो सबसे left वाला graph है, it is the most potent drug. Whereas if I talk about efficacy, efficacy is told by the height of the graph. ठीक है? So जो सबसे ज़्यादा height वाला graph है, that drug is the most efficacious. Okay? Now talking about this. So option A says drug B is the most potent. Yes, it is on the extreme left, and therefore it is the most potent drug. So this is a true statement. Drug C is more efficacious than drug D. Usually does not seem, because drug D का जो graph है, it is going higher than drug C now. It has started. ठीक है? Therefore we cannot comment that drug C is more efficacious than drug D. Which is the most efficacious drug out of this? Drug A is the most efficacious out of this. Okay, drug B is the most efficacious. No, it has the lowest height. Therefore, drug B is the least efficacious drug. Okay, and drug A has the highest potency. No, drug B has the highest potency, followed by drug A. So here the answer would be option number A. कोई दिक्कत नहीं है इसमें. This is important about your log DRC. Question number 9 now. Which of the following statement will be true about a highly ionized drug? So now there can be two types of drugs. Ones which are lipid soluble and second which are water soluble. So the drugs which are lipid soluble, they will be non-ionized drugs. They would be non-ionized drugs, or we can call them non-polar drugs. Whereas the water soluble drugs, they will dissociate. They will dissociate. Okay, and therefore they would be ionized drugs or polar drugs, you can call them. Membranes, usually the cell membranes are made up of. The cell membranes, they are mainly made up of lipids, and therefore the lipid soluble drugs can easily pass the cell membrane. Okay, therefore the lipid soluble drugs would be the lipid soluble drugs will have high absorption. Okay, the lipid soluble drug will have high absorption because they can easily cross the barriers, they can easily cross the membranes. Therefore the lipid soluble drugs will have high absorption, whereas the water soluble drugs will have high excretion. The lipid water soluble drugs will have high excretion because the water soluble drugs, they cannot cross the plasma membrane, or they cannot cross the cell membrane, and therefore they will always remain inside the blood. If they remain inside the blood, they will go to the kidneys, and from there they will be filtered out of the body. Okay, so excretion ज़्यादा water soluble, absorption ज़्यादा lipid soluble, distribution ज़्यादा lipid soluble. Distribution क्या होता है? Drug कितनी distributed है throughout the body, various tissues of the body. And if it needs to enter the tissue, it should cross the cell membrane, which are lipid again. So therefore, lipid soluble drugs have high volume of distribution. Lipid soluble drugs will have high volume of distribution, whereas water soluble will have low volume of distribution. Plasma concentration किसका ज़्यादा होगा? Plasma concentration would be more for the water soluble drugs because they will remain inside the plasma and cannot cross the cell membrane. इतना याद रख लो, वॉल्यूम ऑफ डिस्ट्रीब्यूशन इज इनवर्सली प्रोपोर्शनल टू द प्लाज्मा कंसंट्रेशन. जितनी ड्रग ज्यादा डिस्ट्रीब्यूट होगी उतनी कम प्लाज्मा में प्रेजेंट होगी. ठीक है, एंड प्लाज्मा कंसंट्रेशन वुड बी लेस विद द लिपिड सोल्यूबल ड्रग्स. नो इश्यूज टू एनीबॉडी. क्लियरेंस इज यूजुअली मोर विद द वाटर सोल्यूबल ड्रग्स बिकॉज़ दे आर एक्सक्रीटेड आउट मोर बाय द किडनीज. ठीक है, गॉट इट. सो एटलीस्ट इतनी चीजें तुम्हें याद होनी चाहिए. And if I ask you which is the at least pharmacokinetics सबको पता होगा. ADME, what is ADME? Absorption, distribution, metabolism and excretion. So if I ask you, which is the most important, this was a previous year question, इसलिए पूछ रहा हूँ, which is the most important factor in absorption of a drug? Very good. It is lipid solubility. Please remember, the most important factor in absorption of a drug is lipid solubility of a drug. जितनी ज़्यादा lipid soluble, उतना अच्छा absorption और उतना ज़्यादा volume distribution. ठीक है? So option A says it crosses. It is a highly ionized drug. मतलब कौन सी drug है ये? Water soluble drug. It crosses placental barrier easily. No, it is made up of lipids. Therefore, it cannot cross the placental barrier easily. Option B says it is excreted mainly by kidneys. Yes, because it remains inside the plasma and therefore mainly excreted by the kidneys. Option C says it accumulates in the cellular lipids. No, the lipid soluble drug can actually accumulate in the cellular lipids. Is well absorbed from the intestine. Absorption is better seen with lipid soluble drugs. Okay, therefore it is also not true because intestinal cells का भी cell membrane किससे बना हुआ होगा? Lipid से. Therefore the lipid soluble drugs will show more absorption. No issues with this, anybody? Okay, and therefore the water soluble drugs usually, if their absorption is very less, we will give them in parenteral route. Enteral routes are the ones where the absorption will be taken place by the intestines. These are either the oral route or the rectal route. Whereas the parenteral routes are the ones where we will surpass the intestine. Those are your injectable routes, like your intravenous, intramuscular, subcutaneous. Okay, even non-injectable routes like transdermal, inhalational, or nasal route. No issues to anybody? 100%. Again, easy questions here. 100% bioavailability is seen with intravenous route. And what is bioavailability? The fraction of the drug which will reach the systemic circulation in an unchanged form. That is what is bioavailability. Question number 10. These are the general pharma questions which usually ask either the graph or the lipid and water soluble drugs, or sometimes they can even ask you if an acidic drug is there, that would be more absorbed in which medium? Acidic or so more absorption takes place in the same medium. Acidic drug is more absorbed in acidic medium and alkaline more absorbed in alkaline medium. So if there is acidic drug poisoning, something like aspirin ki poisoning hai, we will give bicarbonate to the patient, sodium bicarbonate, for causing post alkaline diuresis. That is the funda. Vice versa is done with amphetamines usually, which are alkaline drugs, morphine-like drugs, which are alkaline. Therefore, we will give ammonium chloride to the patient that will lead to post acidic diuresis. No issues to anybody? Question number 10 now. A younger female presented with left-sided severe throbbing headache associated with nausea, vomiting, phonophobia and photophobia. Characteristic: irritation to sound and irritation to light. Which of the following drug can provide immediate relief to the patient? What is your provisional diagnosis? So, if it is a younger female presenting to you with a unilateral throbbing headache, definitely the diagnosis is more likely to be migraine. What is the criteria for it? Pound criteria. P for pulsatile in nature. O for one-day illness. That is, each episode of migraine usually goes off within 24 hours. U for unilateral. N for nausea and vomiting. D for disabling in character. मतलब वो इंसान कुछ काम करने लायक नहीं रहता. ठीक है? That is what is a migraine episode. Now this migraine is usually, what is the most important or the most accepted hypothesis? It is due to vasodilation. Okay, of which vessels? In the meningeal vessels. Okay, it is due to vasodilation of these meningeal vessels, and this vasodilation is due to release of CGRP. It is due to release of the CGRP, calcitonin gene-related peptide. So what should be done? We can usually give the drugs which will inhibit the CGRP release. The drugs which will inhibit the CGRP release. And which are the drugs which will inhibit CGRP release? Drugs like, usually drugs like, so 5-HT1B 1D agonist. अरे भाई क्या हो गया? 5-HT1B 1D agonist, and these 5-HT1B 1D agonists are drugs like triptans. That is your sumatriptan, rizatriptan, okay, fruvatriptan, all of these drugs. Whereas the other drugs which also act by the same mechanism, that is 5-HT1B 1D agonism. These are drugs like ergotamine. But why triptans are the better drug and not ergotamines? Because ergotamines can lead to toxicity. And what is the important funda? What is the important side effect of these ergotamines? They will cause extreme vasoconstriction of the peripheral vessels, and that can lead to gangrene. This was a question in August 2020 examination. Which among the following drug is responsible for causing gangrene in in migraine usually? There was a longer question. Okay, so that was asked usually. Okay, they did ask. They did ask what is the cause of gangrene and what is the treatment of gangrene, and there were two options in each of them. Okay, so the answer was dihydroergotamine, which is the cause of gangrene, and the treatment was propranolol, which is usually given. Non-selective beta blocker was given. No issues till here, anybody? Yeah, ergot are very less likely used. Not in cases of nowadays, not in practice. Nowadays, not in practice at all. Okay. Apart from this, so we have 5-HT, 1D and 1D agonist, which will lead to vasodilation. So yaad rakhna, when these meningeal vessels are dilated, they will irritate the meninges and that will cause headache in the patient. Okay, therefore we need to do vasoconstriction. Okay, first of all, it is done by inhibiting the vasodilation with the drugs like 5-HT, 1D, 1D agonists like triptan or ergotamine. Second, the drugs which are used, that is 5-HT, 1F agonist. And these 5-HT, 1F agonists, these are drugs like Ditans, Lasmiditan. Okay, very good. The new drug that is used, it is a 5-HT 1F agonist known as Lasmiditan. We have a question further. ठीक है? याद रख लो. बाकी आगे देख लेते हैं migraine. ठीक है? बाकी बता दूंगा. So here the fastest relief is usually seen with the triptan drugs, and that is sumatriptan. Please remember. Okay, it is sumatriptan. No issues with this, anybody? So that is the thing. Okay, so it is a 5-HT 1B 1D agonist, and these are the drug of choice for acute attack of migraine or acute severe attack of migraine. Very good. For acute migraine, answer was NSAIDs, but acute severe migraine, then your answer changes to triptans. And this is important thing here. One of the important topics is migraine from pharmacology. Every time or every alternate time there has been a question on migraine. Okay, so migraine is one of the important topics even for NEET PG and for FMG as well. No issues till here, anybody? And जो medicine में थे उनको पता ही है. For basilar migraine, what was the drug of choice for prevention? For basilar migraine, it was topiramate. Please remember. Okay, so drug of choice for prevention of basilar migraine, अगर मैं पूछूं, then the answer would be topiramate. Otherwise, the drug of choice for prevention of migraine, only migraine, then your answer is propranolol. Okay, drug of choice for prevention of migraine, answer is propranolol. But drug of choice for prevention of basilar migraine, then your answer should be topiramate. Question number 11, if I talk about, a patient has been prescribed acetazolamide in his therapy for glaucoma. Acetazolamide is it is not a good diuretic. Very good. It is carbonic anhydrase inhibitor. Please remember this. Okay, the drug, it hits the carbonic anhydrase enzyme non-competitively. Okay, there are three types of enzyme inhibition usually. Which of the following is the effect of this drug now? So there are three types of enzyme inhibition or drug inhibition. सबसे पहले important, it is competitive inhibition. Second is a non-competitive inhibition, and third is the uncompetitive inhibition. ठीक है? Competitive inhibition usually क्या होता है? This is your enzyme. Okay, this is your enzyme and the substrate. This is the substrate. Okay. This is the substrate and this is the drug. Okay, the substrate and the drug, both of them are competing to bind at the same site. दोनों को competition करनी पड़ेगी, ठीक है? And here we need to check for two factors. One is the Km, that is the Michaelis-Menten constant, or we can call it a substrate concentration. And the second one, you need to remember, it is the Vmax, the maximum inhibition की बात करता हूँ. Here we याद रख लो, अगर तुम्हें कंपटीशन चल रहा है तो क्या होना चाहिए? एक का कंसंट्रेशन ज्यादा होना चाहिए, ठीक है? सो देयरफॉर प्लीज रिमेंबर, वी नीड टू इंक्रीज द कंसंट्रेशन ऑफ द सबस्ट्रेट. So you need to increase the concentration of the substrate, तभी वो जीतेगा और तभी वो बाइंड करेगा. Therefore here what will happen? Here we need to increase the Km, but the क्या हो गया भाई? Now I hope that you can hear me. Competitive inhibition, you need to increase the substrate concentration to keep the velocity of the reaction same. for the drug to bind. Okay, so there is no competition. वो कोई मतलब ही नहीं है. Okay, so anytime, even if we increase the concentration of the substrate, the inhibitor or the drug is going to bind at any cost. Okay, now the substrate, even if you increase the substrate concentration at any level, then also the drug is going to bind because it has another site. It does not need to compete with the substrate. Okay, and therefore, if it is going to bind at any cost, therefore the Vmax or the velocity of the reaction is going to decrease. Whatever you do, the reaction velocity will decrease. So in non-competitive inhibition, the velocity of the reaction decreases. So कोई फायदा है substrate concentration बढ़ाने का? नहीं है. So keep the Km on the substrate concentration same. That is the thing. ठीक है? पहले में हम Vmax same रखने के लिए हम substrate concentration बढ़ा रहे थे. But इधर हम कितना भी substrate concentration बढ़ा ले, Vmax कम होने ही वाला है because the drug is having another site or the inhibitor is having another site to bind. ठीक है? So no competition is going to occur. And in uncompetitive, please remember both of these substrate concentration as well as the Vmax are going to decrease. Here they are talking that the drug is inhibiting this enzyme non-competitively. So what will happen? The Km will remain same and there will be decreased Vmax. No issues with this, anybody? Decrease in both Km and Vmax is seen with uncompetitive inhibition. Decrease in Km is not seen. Increase in Km is seen with competitive inhibition. Question number 12 now. A farmer was brought. Sarkari question. A farmer was brought to emergency in an unconscious state with excessive salivation, lacrimation, and urine incontinence. मतलब urine बहे जा रही है. ठीक है? So there is no control over urine. That is what is incontinence. On examination, pinpoint pupils are noted. ठीक है? His wife gives history that he has taken some unknown poison. All the below given statements are true except. So if a farmer comes to you with some unknown poisoning, the most accessible to him is the insecticides or the pesticides, which contain nothing but organophosphates or the carbamates. Okay, that is OPC. Organophosphate, carbamates for the pesticides or insecticides. And whenever patients take this organophosphates or carbamates, these are reversible or irreversible inhibitors. So these are nothing but the irreversible inhibitors of which enzyme? Acetylcholine esterase. If they are irreversibly inhibiting this acetylcholine esterase enzyme, तो क्या होगा? Acetylcholine will not be degraded. It will not be degraded. As it is not being degraded, therefore the levels of acetylcholine will keep on increasing. तो बहुत ज़्यादा acetylcholine हो जाएगा. And when there is excess of acetylcholine in the patient, that leads to cholinergic poisoning. And cholinergic symptoms will appear in the patient. That is what is increased secretion. Everywhere the secretions will be increased. Lacrimation, urination, okay, salivation, sweating, everything is usually increased. No issues with this. And as we know, the cholinergic poisons or the cholinergic drugs will cause meiosis or mydriasis at the pupil. It will cause meiosis at the pupil due to M3 receptor stimulation. And as they cause meiosis at the pupils, therefore the patient will have pinpoint pupils. No issues with this. And the patient can even have respiratory distress because M3 receptor stimulation in the bronchus can cause bronchoconstriction. Urinary incontinence is definitely, first of all, due to increased urination. But second, it is also due to the contraction of the bladder muscles, because this bladder muscles also have which receptors over it? M3 receptors. And activation of this M3 will cause contraction of this urinary bladder muscles, causing urinary incontinence. No issues with this, anybody? So I hope at least ये बात याद रखो लो, एक करके ANS खत्म करेंगे. So M1, M2 and M3 receptors are present. M1 receptors are present on the stomach. M1 receptors are mainly present on the stomach usually, and they are responsible for secretion of HCl, that is acid secretions usually करेंगे, ठीक है? Whereas M2 receptors, they are mainly present on heart, and they will cause stimulation or depression of heart. So याद रखना, parasympathetic system increases everything but depresses the heart. On the other hand, sympathetic system usually stimulates, ठीक है, but decreases the other things. ठीक है, stimulates the heart but decreases the other effects. No issues with this. So M2 receptor agonism or M2 receptor stimulation will cause myocardial depression. That will cause bradycardia and decreased blood pressure in the patient. ठीक है? And M3 receptors की अगर मैं बात करूँ, these are usually present on bladder, and therefore they will contract or they will relax the bladder. They will increase the contractility of the bladder, that will lead to increased urine output in the patient. Okay? They are also present on the bronchus. And what will they cause in the bronchus? They will cause bronchoconstriction. M3 receptor, muscarinic receptors, कौन से सिस्टम क्या है? Parasympathetic nervous system. Parasympathetic nervous system कब एक्टिव होती है? When you are relaxed, when you are sitting inside your bed. जब तुम अपने बेड में बैठे हो, तभी क्या होता है? यूजुअली तुम्हारा HCl सिक्रीशन ज्यादा होता है, ठीक है? तभी क्या होता है? हार्ट रेट तुम्हारा कम होता है. तभी क्या होता है? यूजुअली वॉशरूम जाने का मन करता है. जब सामने चीता देखते हो, तब वॉशरूम जाओगे क्या? सब भूल जाओगे. That what is happening. ठीक है? And here you are relaxed. Therefore, you don't need the bronchus to be dilated. Therefore, the bronchus undergo bronchoconstriction. Pupils पे भी M3 receptors होते हैं. And in pupils, what will happen? There would be meiosis because you need to sleep now, and therefore there would be meiosis due to parasympathetic activation. No issues with this. And even in glands, they will need to increase secretion. So every glandular secretions would be increased, and if this M3 receptors are stimulated. कोई दिक्कत नहीं. हाँ बोलो. किसमें? Attention usually बढ़ाता है, but जो एक्टिविटी होती है ना, वो एक्टिविटी नहीं बढ़ाता, बस अटेंशन बढ़ाता है और कुछ नहीं. अटेंशन बढ़ाता है, एक्टिविटी नहीं बढ़ाता. मैं कहीं भी अटेंशन का जिक्र किया ही नहीं. मियोसिस मतलब मियोसिस होता है, अटेंशन स्पैन बढ़ाता है, ठीक है? मियोसिस करवाता है. देयर आर डिफरेंट एक्शंस ऑन द सीएनएस एंड ऑन द peripheral structures. No issues with this, anybody? Now talking about this one again. Option A. Array. So if it is OPC, it is an irreversible inhibitor of acetylcholinesterase, increasing acetylcholine to an excess level, and that will cause all the cholinergic symptoms in the patient. Now, if I talk about option A says pralidoxime is given in slow IV infusion as a rapid or slow. So pralidoxime is usually, pralidoxime is what? Pralidoxime or diacetyl monoxime. Very good. These are acetylcholinesterase reactivators. These acetylcholinesterase reactivators are the most specific drug. These are the most specific drug. They are not the drug of choice. Please remember. Though they are reactivating the acetylcholinesterase, but they take some time to act. Okay, they usually take some time to act, and therefore these acetylcholinesterase reactivators like pralidoxime or diacetyl monoxide are not the drug of choice because they are not the life-saving drugs in cases of OPC poisoning. Okay, therefore they are the most specific drug only. Okay, and pralidoxime or PAM is not used in carbamate poisoning. It cannot be used in carbamate poisoning. It is only restricted to be used in the organophosphate poisoning. ठीक है, याद रखो. Option B says atropine is a life-saving drug for this poisoning. Yes. Why? Because atropine blocks all the muscarinic side effects of this acetylcholine, and therefore atropine will save the life of this patient. ठीक है. Option C says enzymes are reactivators of acetylcholinesterase. Yes, enzymes are reactivators of acetylcholinesterase. Option D says pralidoxime can be given in carbamate poisoning. अभी मैंने मना किया. These are not given in carbamate poisoning. The reason being, pralidoxime and this carbamates and this pralidoxime both need to bind at the same site. अगर दोनों को उसी site पे bind करना है, carbamates have already occluded that site. Now where the pralidoxime is going to bind? Therefore, in carbamate poisoning, we cannot give pralidoxime to the patient. ठीक है? That is the thing. ठीक है? Now, if they ask you, atropine is given till what time? So, atropine is given till the signs of atropinization start. And what is the most common sign of atropinization? Very good. Most common sign of atropinization is mydriasis. So, you will keep on checking for dilatation of pupil. As soon as the pupils are dilated, you can stop giving atropine to the patient. Okay? This is the most common sign. But if they ask you, which is the most specific sign of atropinization? Very good. If they ask you, the most specific sign of atropinization is decreased secretions. Okay, that is decreased secretions. You are not able to assess decreased secretions. Therefore, the most accessible way is to assess the pupillary reactions. Like if the pupils dilate, you can stop giving the drug. कोई दिक्कत नहीं है इसमें. Most common sign that we use usually in hospitals, it is mydriasis. Best sign, most specific sign is definitely decreased secretions. theoretically तुम बोल सकते हो decrease secretions, but you cannot assess decrease secretions properly. ठीक है? Therefore, definitely you need to assess mid-reassess usually. ठीक है? No issues to anybody? Question number 13. Which among the following is a pair of drug and its mechanism of action is incorrectly matched? So, atorvastatin, it is the HMG coenzyme synthetase inhibitor. Rather, it is the HMG coenzyme reductase inhibitor. And this HMG coenzyme reductase is the rate limiting enzyme of गप्पे घर पे जाके मार लेना भाई, थोड़ा अटेंशन दे दो, ठीक है? The HMG coenzyme reductase is a rate limiting enzyme for which synthesis? It is a rate limiting enzyme. Biochem हो चुका है तुम्हारा. It is the rate limiting enzyme of cholesterol synthesis. Please remember this, okay? And therefore, if this enzyme is inhibited, there would be decreased production of endogenous cholesterol, and that is what is the basic problem in case of hyperlipidemia or dyslipidemia. So, if there is hyper or dyslipidemia, the drug of choice, if they ask you, answer should be statins, and we can use longer acting statins like atorvastatin or rosuvastatin. But the longest acting statin, anybody? Answer is rosuvastatin. The longest acting statin is rosuvastatin. Okay. Other statins can be pravastatin, simvastatin, वगैरह. ठीक है? But the longest acting one is rosuvastatin. And therefore, atorvastatin and rosuvastatin can be given at any time of the day. But the other statins are usually given at the night itself. No issues with this. Then if I talk about option number B, it says cholesterol. So here your answer is option E. Cholestyramine is a bile acid sequestrant. Yes, it is also called as a bile acid binding agent known as BABA. Drugs like cholestyramine, cholestyramine, so cholecyvalam. Okay? The only oral drug out of these BABA is only oral drug because it is easily palatable. Answer is cholecyvalam. Cholecyvalam can be given orally. The others are not given usually orally because they are not easily palatable. Cholestyramine and cholestyramine. Chole नाम में आ रहा है. Chole is nothing but bile. So wherever chole comes, that is what is bile. ठीक है, याद रखो. Easy है याद रखना. And these BABA, they are usually the drug of choice for hyper or dyslipidemia. In which condition? In pregnancy and children. Usually in pregnancy and children, the drug of choice for hyper or dyslipidemia. Answer is BABA drugs. ठीक है? Option C says ezetimibe is an intestinal cholesterol absorption inhibitor. Yes, it is an intestinal cholesterol absorption inhibitor. That is called as ezetimibe. This was one of the options in NEET PG. Okay? And gemfibrozil, any of the fibrates, gemfibrozil, fenofibrate. Okay? So all of these fibrates, these are PPAR alpha stimulators. But after they stimulate this PPAR alpha receptor, once they stimulate this PPAR alpha receptor, it activates the anabolic enzyme like the LPL, that is lipoprotein lipase. This lipoprotein lipase is activated, and ये lipoprotein lipase क्या करती है? It breaks the triglycerides. It mainly breaks triglycerides, therefore decreasing the level of triglycerides inside body. No issues with this. So if they ask you highest chances to lower the triglyceride are seen with highest triglyceride lowering potential is seen with fibrates. Okay, that is the reason why highest triglyceride lowering potential is seen with fibrates. Please remember. Okay, no issues with this. Highest HDL cholesterol increasing property, because we know LDL cholesterol is bad and HDL cholesterol is good. The highest HDL cholesterol increasing property. Very good. It is niacin. That is what is vitamin B3. That is also known as vitamin B3. And if you give this vitamin B3 on a long term, that will lead to side effects like flushing or itching. There can be side effects like flushing or itching in the patient. No issues with this, but it is the cheapest drug that is available, and that is the best drug to increase the HDL cholesterol. If they ask you for increasing triglyceride, decreasing triglyceride, I have already told you answer is fibrates. And if they ask you the best drug to decrease LDL cholesterol, the best drug to decrease LDL cholesterol, answer is statins usually. कोई दिक्कत नहीं है इसमें, ठीक है? तो याद रखो. You'll get the PPT, don't worry. ठीक है, समझ गए सब? So these are the important things about dyslipidemic drugs. Okay, if you think it is a smaller topic, this has always on alternative or दो exams के बाद it has always been asked in NEET PG and even in INR CT examinations. ठीक है? करूँ. A patient presented to the emergency room with severe headache and vomiting. On examination, the blood pressure was 220 by 130 mm of Hg, and also papilledema is seen. ठीक है, papilledema is nothing but dilatation and tortuosity of the retinal vessels usually, which gives angry sun appearance on fundoscopy. ये बता दिया था. Okay, and that is what is suggest you uncontrolled hypertension or hypertensive emergency or urgency. Hypertensive emergency. Whenever the blood pressure increases too much, okay, then that is what is called as hypertensive crisis. It can be either a hypertensive emergency or it can be hypertensive urgency. Hypertensive urgency matlab only the blood pressure is more. Kitna? More than 160 by 110, but there is no end organ damage. But in hypertensive emergency, the blood pressure is more than 160 by 110 along with presence of end organ damage. Okay? Then that is called as hypertensive emergency. कोई दिक्कत नहीं है इसमें. Now here we can see features of retinal damage, and therefore it is suggestive of hypertensive emergency in this patient. And the blood pressure is also 220 by 130. What is the mechanism of drug of choice for this action? What is the drug of choice for hypertensive crisis or emergency? I told you nicardipine, yaad rakh lo. It mainly acts on which channels? Calcium channels, but which type? The T type. Arey L kitna rakh liya? T type of calcium channel blockers. It mainly acts on the brain. So it can be used in case of intracerebral hemorrhage or in cases of hemorrhagic stroke. But other types usually, okay, जो बाकी के type का hypertension, uncontrolled hypertension होता है, when there is end organ damage, the better drug according to JNC8 that should be used is sodium nitroprusside. Okay, that is sodium nitroprusside. And sodium nitroprusside will what? It will release, it will stimulate. Sodium nitroprusside releases what? Nitric oxide. That releases nitric oxide. Okay, this nitric oxide. Nitric oxide stimulates which enzyme? Enzyme. So it stimulates enzyme known as guanylyl cyclase. As it stimulates the enzyme guanylyl cyclase, it leads to increased production of cyclic GMP. And as the cyclic GMP, it activates the protein kinases. Okay, it activates protein kinases. Okay, and due to that, what usually happens, as the protein kinases are activated, the phosphatase enzyme is inhibited, and therefore the patient will have vasodilation. Okay, the patient will have vasodilation. Final action is vasodilation, and if vasodilation occurs usually, then that will lead to decrease which load, pre or after? दोनों हो सकता है. There can be decreased pre-load if the veins are getting dilated. There would be decreased afterload if the arteries are getting dilated. Okay, no issues with this, anybody? So there would be decreased pre and afterload, and therefore there would be decreased blood pressure in the patient. No issues with this, anybody? So sodium nitroprusside acts by which mechanism? Stimulation of guanylyl cyclase. Inhibition of sodium chloride transport, it is done by thiazides. Very good. In which part of the nephron? DCT, distal convoluted tubules. And thiazides are the first line drugs for hypertension and not hypertensive crisis. Yaad rakh lo. Okay, so thiazides are usually weaker drugs. They are longer acting drugs, and therefore they are used as a drug of choice for hypertension. But they are not the drug of choice for hypertensive crisis. Hypertensive crisis, when there is only CNS symptoms, answer can be nicardipine. But when there are other symptoms, the answer should be sodium nitroprusside, because it is the fastest acting drug. Okay, the other drug which belongs to the same group, that is also known as hydralazine, and therefore hydralazine can be used in hypertensive emergency in pregnancy, but still it is not the drug of choice in hypertensive emergency in pregnancy. Now अगर मैं pregnancy की बात करूँ, we have already discussed drug of choice for hypertension in pregnancy. Very good. It is oral labetalol, which is a alpha blocker or a beta blocker. Alpha plus beta blocker. Please remember this. Okay. If I ask you what is the drug of choice for hypertensive crisis and pregnancy, the answer will remain same. It will only change to IV labetalol. अगर जो तुम्हारा question था, in that, it was asked what is the drug of choice for hypertension in pregnancy, but this labetalol was not an option. Then the other drug that can be used is alpha methyl dopa. Okay? So the drugs which can be remembered are better mother care during pregnancy. Okay? This is a common one. So that, okay, so better mother care during pregnancy. These are the usual drugs which are safe anti-hypertensive drugs during pregnancy. Safe drugs during pregnancy. Beta goes for beta blocker, that is alpha plus beta blocker known as labetalol. Okay? Mother goes for which dopa? Alpha methyl dopa. Second best drug. Second best I'm saying. Okay? JNC8 says it is drug of choice. But overall Harrison does not say it is a drug of choice. Even Williams does not say. तो इसीलिए ये नहीं हो सकता. ठीक है? केयर का मतलब होता है क्लोनिडेन. Alpha methyl dopa and clonidine both are agonist या antagonist of the alpha receptor. Both of them are alpha 2 agonist. Please remember, they both of them are alpha 2 agonist, and alpha 2 receptors are present on presynaptic neurons usually. They are also present on postsynaptic, but predominantly on the presynaptic neuron, and therefore they will act as brakes over the adrenergic system. ठीक है? मैं कुछ और बोल सकता था बट छोड़ दो. ठीक है? They will act as brakes over the adrenergic system. मतलब खुद की लेवल खुद ही कम है. ठीक है? Then if I talk about during, that is nothing but your dihydropyridines usually. ठीक है? Dihydropyridines. Drugs like calcium channel blockers like nicardipine, nimodipine. Verapamil is not a dihydropyridine. Verapamil and diltiazem are other calcium channel blockers. DHPs जो होते हैं वो अलग होते हैं. Okay? Dihydropyridines are only dipine drugs. Nimodipine, nicardipine, clevidipine, all of these. And pregnancy goes for alpha blocker, alpha 1 blocker to be specific. It goes for alpha 1 blocker known as prazosin. कोई दिक्कत नहीं है इसमें. So याद रखना Harrison में usually जो दवाई दी गई है ना nicardipine, it can be used for hypertensive emergencies, but it is more specifically only used for cerebral pathologies like the hemorrhagic stroke. Therefore, it was not found effective on the other patients. So अगर practice में देखेंगे तो sodium nitroprusside is the one that we commonly use. ठीक है? For emergencies. ठीक है? तो बाकी सब Harrison's के guidelines follow होते हैं except यहाँ पे because it does not fulfill. आगे बढ़ते हैं. Question number 15 now. PSM का question है. With respect to clinical trials, which of the following is most correct? तो सबसे पहले अगर मैं pre-clinical trials की बात करता हूँ, pre-clinical trials are always done on animals, whereas clinical trials are done on humans. Okay? Clinical trials के कितने phases? और एक ऐड कर दिया गया phase 0. Not mandatory. See, not mandatory, but it is usually done. And what is phase 0? Phase 0 is nothing but micro dosing. सबसे कम dose, 100 dose of a drug is given usually. Then phase 1 is what? Phase 1 is done on unit of study. Phase 1 is done on patients or healthy people. It is done on healthy human volunteers. Phase 2 is done on healthy human volunteers or patients. So from phase 2 onwards, we will take patients in the study. Okay, these are the patients in the study from phase 2 onwards. अगर मैं पूछूं किसके लिए यूज करते हैं, phase 1 is generally used for phase 1 is generally used to assess the safety of a drug, or you can say non-toxicity of a drug, or the maximum tolerable dose of a drug. Even toxicity can be called. ठीक है? Non-toxicity, toxicity, safety and maximum tolerable dose. सबसे पहले efficacy कहाँ देखी जाती है? Efficacy is determined in phase 2. Efficacy is determined in phase 2, and efficacy confirmation occurs in phase 3 usually. And here in phase 3, we will do comparison with the existing drug. We will do a comparison with the existing drug. No issues with this, anybody? We will do a comparison with the existing drug. Means we will carry out a randomized controlled trial. तो याद रखना, clinical trial is not a complete RCT. अगर वो पूछेंगे randomized controlled trial is carried out in which phase of clinical trial, answer should be phase 3 of clinical trial, जहाँ it is compared with the existing drug in the market. ठीक है? And lastly, phase 4 is done for long-term and rare side effects of the drug. Okay, it is done for long-term and rare side effects of the drug. Usually, marketing is done after phase 3. Marketing is done after phase 3, and therefore phase 4 is considered as a post-marketing surveillance of the drug. No issues till here? Therapeutic index तुम phase 1 में ही देखो, ठीक है? That is the one. No issues till here, anybody? Option A says phase 1 involves the healthy volunteers. That is a true statement. Yeah, true. Phase 2 involves use of a new drug in large number of patients. It involves the use of a new drug for efficacy determination, but only in smaller group of patients like 20 to 200. Whereas in phase 3 we can take patients up to 5,000 in the study. ठीक है, याद रखना. So it is not a large number of patients, rather on a smaller group of patients. ठीक है, तो phase 3 involves determination of therapeutic index of a drug. That is done in rather phase 1 of the clinical trial. Phase 4 involves detailed study of toxic effects. Again, toxic effects are usually studied in phase 1 of the clinical trial. कोई दिक्कत नहीं है. Question number 16 now. An 82-year-old patient presented with acute episode of breathlessness. Chest X-ray shows pulmonary edema. History reveals that the patient has uncontrolled hypertension and is not taking medications regularly. So if he is having uncontrolled hypertension and if he is not taking medications regularly, he is non-compliant, that can lead to heart failure in this patient, and that can land up the patient in pulmonary edema. Which should be the management of this patient? So अगर यहाँ पे देखोगे pulmonary edema का management is remembered as LMNOP. ठीक है? L goes for a diuretic, and the diuretic that we use is a loop diuretic, that is mainly Lasix, that is your furosemide, which is used. M goes for morphine, which is a opioid. Okay, so morphine is generally used. N goes for nitroglycerin mainly. Okay, it is used for IV nitroglycerin is given to the patient for dilation of vessels. O goes for oxygen. Okay, O goes for oxygen, and P goes for positioning. P goes for positioning. That means the head end of the patient should be elevated to decrease the respiratory distress in the patient. ठीक है, that is the thing. क्योंकि pulmonary edema क्या होता है? पानी भर गया lungs में. So therefore the patient will have breathlessness and respiratory distress. So therefore, to give symptomatic relief, we can elevate the head end of the patient. That is what is known as positioning. And oxygen मतलब भी तुम्हारा positive pressure ventilation. No issues with this, anybody? So that is the management. So what should be given? Option A, IV nitroglycerin. Recent question again. No issues there, yeah? Question number 17, if I talk about a child born by normal vaginal delivery. ठीक है, तो फार्मा याद रख लो यार. फार्मा बस फार्मा नहीं होती है, फार्मा में मेडिसिन का भी एस्पेक्ट होता है और ये मेडिसिन की ट्रीटमेंट रेजिम है पूरी. ठीक है, तो बस एक ड्रग मत याद करके जाओ, नाइट्रोग्लिसरीन. मेडिसिन में भी ये भी पढ़ाया जाएगा, तो याद रखना LMNOP इज द मैनेजमेंट ऑफ पल्मोनरी एडिमा. ठीक है, and भले ही तुम्हें एग्जाम निकाल लो, this is a very common thing that comes to you, presents to you in emergency. ठीक है, तुम्हें पता होना चाहिए कि क्या करना है क्या नहीं करना हार्ट फेलियर के पेशेंट के साथ. ठीक है, a child born by normal vaginal delivery develops repeated attacks of jerky movements of the hands and neck. So he is developing jerky movements of neck usually. इसको क्या बोलोगे? तो a child who is born, that means the child is an infant. Okay, and immediately he is developing this jerky movements of neck. These are nothing but a type of seizures called as infantile spasm, also known as with seizures. They look like he is doing a salam. Therefore, these are also called as salam seizures. So, infantile spasms or salam seizures. Okay, and EEG confirms our diagnosis because the EEG is showing hips arrhythmia. Hips arrhythmia is nothing but a chaotic rhythm in all the EEG leads. There is a chaotic rhythm, okay, in all the EEG leads. Which among the following is the anti-epileptic of choice? Answer is injection of adrenocorticotropic hormone, that is the ACTH. And we have discussed, whenever the patient will have infantile spasms with tuberous sclerosis, very good, then the drug of choice would be vigabatrin. Then the drug of choice is vigabatrin. Okay, tab your answer would change. No issues to anybody? For most of the types of epilepsy, the drug of choice is valproate. For seizures like generalized tonic-clonic seizures, seizures like atonic seizures, seizures like myoclonic seizures, okay, and even in cases of absence seizures. But when the child is more than 4 years of age, and ethosuximide is the drug of choice for absent seizures when the child is less than 4 years of age. कोई दिक्कत नहीं है इसमें, तो ये important है. Drug of choice for myoclonic epilepsy answer would be valproate. Drug of choice for myoclonic seizures में क्या use कर रहे थे? Valproate was used ना. Therefore for myoclonic epilepsy which is generally seen during adolescence, ठीक है, जिसको क्या बोलते थे अपन? कौन सा syndrome? Juvenile myoclonic epilepsy is also known as which syndrome? Jan's syndrome. And in Jan's syndrome also, the drug of choice is sodium valproate. No issues with anybody? Valproate has multiple actions, but the main predominant action of sodium valproate is blocking of which channels? Sodium channels. It is a sodium channel blocker predominantly. ठीक है? कोई दिक्कत नहीं है इसमें. तो एटलीस्ट इतनी ड्रग्स तुम्हें इसमें एंटी-एपिलेप्टिक्स में याद होनी चाहिए. इसके अलावा if they ask you which is the safest anti-epileptic drug in pregnancy, चलो, the safest anti-epileptic drug in pregnancy is levetiracetam. Answer is levetiracetam, followed by lamotrigine. Why is lamo second best? Because it is associated with one side effect that is known as Stevens-Johnson syndrome, जिसमें there is peeling of skin usually. Okay. If I talk about focal seizures, what is the drug of choice for focal seizures? Very good. The drug of choice for focal seizures is carbamazepine. Okay. But in cases of elderly patients, the drug of choice for focal seizures changes to lamotrigine. In elderly patients, the drug of choice for focal seizures is focal, मतलब only involving a group of muscles. ठीक है? तो बस abnormal movement एक ही group of muscles में हो रहे हैं. Then these are called as focal seizures. No issues with this. ठीक है, तो जल्दी से एंटी एपिलेप्टिक्स रिवाइज करेंगे. ड्रग ऑफ चॉइस फॉर इन्फेंटाइल चाइल्ड प्लस अलार्म फीचर्स है ACTI, बट व्हेन द चाइल्ड इज हैविंग ट्यूबरस स्क्लेरोसिस अलोंग विद इन्फेंटाइल चाइल्ड, देन द ड्रग ऑफ चॉइस इज बीटा-actin. Drug of choice for GDCS, myoclonic, absent and atonic seizures, sodium valproate. The highest teratogenicity or highest teratogenic side effects are seen with valproate, and least teratogenic side effect or the safest anti-epileptic drug is levetiracetam, followed by lamotrigine. No issues with anybody? That is the pattern. ठीक है, focal seizures में drug of choice है carbamazepine, whereas focal seizures in elderly the drug of choice है lamotrigine. कोई दिक्कत नहीं है इसमें. Which of the anti-epileptic drugs causes gum hyperplasia? Previous question. Phenytoin. Okay, the drug which causes gum hyperplasia, hirsutella. This drug is what is called as phenytoin. It can be used for which type of seizures? Mainly focal seizures. कोई दिक्कत नहीं है इसमें. ठीक है, तो ये बेसिक याद रख लो. If a child presents to you with febrile seizures, what is the drug of choice? Very good. The drug child presents to you with febrile seizures, then the drug of choice would definitely be benzodiazepines like diazepam. Okay, the drug of choice is diazepam. ठीक है, rectal or IV diazepam should be given to the child. And for maintenance in between the episodes of febrile seizures, you can give oral diazepam or oral clobazam. If a patient, ये previous question था तुम्हारा medicine का, if a patient comes to you with ongoing seizures and you are not able to get an IV access, so the drug which is preferred is very good. It is midazolam. Please remember, it is midaz. Already मैं बता चुका हूँ ये last. It is midazolam because it is given by intranasal route. It is given by intranasal route. So if you are not able to get an IV access in the patient, the drug of choice for seizures, the ongoing seizure episode in emergency, answer is benzodiazepines, and the best drug that we use is IV lorazepam. But if you are not able to insert a cannula, तब क्या करोगे? कहाँ से दोगे lorazepam? Then the drug of choice would be midazolam, that is which can be given intranasally. कोई दिक्कत नहीं है. Otherwise, it is always IV lorazepam, except if you are not able to get an IV access. ठीक है? Rectal diazepam भी दे सकते हो, but in adults, the better drug that we use is intranasal midazolam. In children, we can definitely give rectal diazepam. कोई दिक्कत नहीं है इसमें. ठीक है? What does LD50 signify? LD50. L is what? So it is not loading dose. Please remember, loading dose is different. This is a lethal dose. ठीक है? And lethal मतलब the dose which can kill. So the dose which can kill how many % of animals? 50% of animals. That is what is called as a lethal dose. So the dose at which 50% animals will die. This is known as lethal dose. And what is this formula for LD50 upon ED50? Lethal dose in 50% cases upon effective dose. Very good. It is the formula for therapeutic index usually. Okay, it will show us the therapeutic index of a drug. Okay, कोई दिक्कत नहीं है. And there are some drugs which will have a very narrow therapeutic index. मतलब the same one. From therapeutic effects to toxic effects. इनका escalation बहुत जल्दी होगा. Okay, therefore we will need a close monitoring of this drug, and that is what is called as therapeutic drug monitoring. So therapeutic drug monitoring is usually done for drugs with narrow or broad therapeutic index, or drugs with narrow therapeutic index. The drug like lithium or drugs like barbiturates. Okay. Even drug like digoxin used in congestive heart failure. For these drugs, usually aminoglycosides were antibiotics. These are also drugs with narrow therapeutic index. कोई दिक्कत नहीं है, ठीक है, समझ गए, कोई दिक्कत नहीं थी इसमें. तो AD50 और AD50 is therapeutic index usually. याद रखो. Question number 19 now. A patient presents with chest pain and diagnosed as unstable angina. Unstable angina is the chest pain which will occur on exertion, or the chest pain which occurs on rest. So the chest pain which occurs on rest, that is what is unstable angina. And he was started on tablet aspirin 325 mg. Why? Because what is the treatment regimen in unstable angina? So in cases of unstable angina or in cases of non-ST elevated MI and STEMI, the treatment regime is called as abimona. याद रख लो, abimona. ठीक है, ऐसे याद रख लो, abimona. So A goes for a glycoprotein 2B3A inhibitor, and this glycoprotein 2B3A inhibitor, which is an antiplatelet drug, that is called as AFMGE. It is known as AFMGE. B goes for a beta blocker and a cardioselective beta blocker or a selective beta 1 blocker. It is usually a drug like metoprolol which is used. E goes for a low molecular weight heparin. Very good. Enoxaparin. Parin वाले जो drug होते हैं ना, these are nothing but low molecular weight heparins usually. ठीक है? Dalteparin, enoxaparin, these are nothing but low molecular weight heparin. ठीक है? M goes for morphine, which is given for pain relief. ठीक है? Analgesic के काम पे. O goes for oxygen. N goes for nitroglycerin, and A goes for antiplatelet therapy. Why I will write antiplatelet therapy better than? Because we will give dual antiplatelet therapy nowadays, and the two drugs that are given nowadays, first is the antiplatelet drug called as aspirin, and second antiplatelet drug which is given as clopidogrel. Okay? No issues with this, anybody? That is the treatment for unstable angina or non-ST elevated MI. So here aspirin, what is correct about the mechanism of action of this drug they have asked you. So now this aspirin, it belongs to salicylates, and it is also non-steroidal anti-inflammatory drug, and it is also antiplatelet drug. So yaad rakh lo, at low doses, something like 75 or something like 325 mg, at low doses it has a antiplatelet action, but at high doses, something like 600 mg, it will have a anti-inflammatory action. So अगर anti-inflammatory action चाहिए, you need to give aspirin in high doses to the patient. No issues with this, anybody? That is the funda. So here aspirin, what? It blocks which enzyme? It is the inhibitor of COX, that is your cyclooxygenase enzyme. I hope all of you are quite aware. Arachidonic acid is metabolized, or it is converted by phospholipase A2, which is the rate limiting enzyme of arachidonic acid metabolism. This phospholipase A2 would convert arachidonic acid to if it is acted upon by COX, that is cyclooxygenase, it would be converted to leukotriene by COX. If it is acted upon by cyclooxygenase enzyme, it would be converted to prostaglandins. And if it is acted upon by LOX, lipooxygenase, then it would be converted to leukotrienes. No issues with this. And along with prostaglandins, the another agent that is produced is thromboxane A2. All other prostaglandins will inhibit or stimulate platelet. It will inhibit the aggregation of platelets, except thromboxane A2, which will stimulate the aggregation of platelets, मतलब it will lead to clot formation in the platelets, ठीक है. तो therefore aspirin क्या करेगी? Aspirin will inhibit this thromboxane A2, okay, and as it inhibits the thromboxane A2 or decrease the production of this thromboxane A2, therefore there will be a anti-aggregation of platelets, and that will not lead to clot formation in the patient. And this is how the anti-platelet action of aspirin takes place. कोई दिक्कत नहीं है. And it inhibits which enzyme? Cyclooxygenase enzyme. Now some books definitely say it inhibits COX-1 as well as COX-2. But for anti-platelet action, it has been seen that it mainly selectively inhibits COX-1 more than COX-2. COX-2 पे minimal action होता है उसका. So here the better answer would have been option A. It acts by inhibiting aggregation of platelets because that is the more selective answer. Final action क्या हो रहा है? Even if it is inhibiting cyclooxygenase, it is decreasing the production of thromboxane A2 and finally leading to inhibition of aggregation of platelets. This is the previous year NEET question. Please remember, here if I compare, the better answer would always be inhibition of aggregation of platelets. ठीक है? कोई दिक्कत नहीं है. 75 to 325, मतलब 75 mg या 325 mg दोनों लो डोसेस. हाई डोस मतलब 600 mg यूजुअली. ठीक है? हाँ 160 से ज्यादा, मतलब यूजुअली याद रखो 160 से ज्यादा एंटी इंफ्लेमेटरी एक्शन नहीं आता. एंटी इंफ्लेमेटरी एक्शन इज यूजुअली सीन एट 600 mg, उससे कम होता ही नहीं है. ठीक है, याद रखो. कितना भी एस्पिरिन दे दो चाहो 325 देंगे तो भी एंटी इंफ्लेमेटरी एक्शन नहीं आता. ठीक है. एंटीपायरेटिक भी सेम. एंटी इंफ्लेमेटरी जब आएगा एंटीपायरेटिक कभी आता है. फीवर क्या है? फीवर इज वन ऑफ द साइंस ऑफ इन्फ्लेमेशन, राइट? नो इश्यूज टू एनीबॉडी, दैट इज इंपॉर्टेंट टू बी रिमेंबर्ड. ठीक है. And the other antiplatelet drug that I was talking about, which is clopidogrel, it inhibits which receptors? Anybody? Clopidogrel or ticlopidin inhibits which receptor? It will inhibit ADP P2Y12 receptor. It is an inhibitor of P2Y12 receptor. No issues with this, ticlopidin or clopidogrel. And the third antiplatelet drug we have already discussed, that was apixaban AB, मतलब it will inhibit glycoprotein 2B3A receptor of platelets. It will inhibit the glycoprotein 2B3A receptor. And what happens with this glycoprotein 2B3A receptors? The platelets can attach to each other. ठीक है, platelets can attach to each other. If the glycoprotein 2B3A receptor is inhibited, the platelets cannot attach to each other. That will inhibit the aggregation of platelets again. ठीक है. So these are the three antiplatelet drugs. We will talk about anticoagulants further. कोई दिक्कत नहीं है. Done with antiplatelets. Okay. So the drug which acts as a fibrinolytic agent. कौन कर रहा था fibrinolysis? Tissue plasminogen activator. That was thrombolytic agents like streptokinase, reteplase, alteplase, all of these. The drugs which will inhibit clotting factor 2A and 9A. Both, अगर दोनों काम एक ही ड्रग कर रही है, that is indirect inhibition of clotting factor 2A and 10A. Heparin causes indirect inhibition of clotting factor 2 and clotting factor 10. Okay, no issues with this, anybody? Question number 20 now. A patient of chronic stable angina, मतलब the patient is having only chest pain at exertion or on activity. ठीक है. On rest, the patient does not have any chest pain. Only on exertion or exercise, the patient starts experiencing chest pain. That is what is chronic stable angina. He is having chronic stable angina with pedal edema, breathlessness, okay, rest, right upper quadrant discomfort, and was admitted in ward. अब जिनका मेडिसिन हो चुका है जल्दी. अरे मैं डायग्नोसिस पूछ रहा हूँ. डायग्नोसिस पूछ रहा हूँ. What is your diagnosis, guys? Pedal edema. That means the blood is accumulating usually on the in the body. Okay, breathlessness because there is pulmonary edema, and right upper quadrant discomfort because there is hepatomegaly due to congestion of blood, and that is what is the feature of congestive heart failure. No issues to anybody. This is the feature of congestive heart failure. ठीक है, mainly right sided congestive heart failure होगा because these signs are usually pulmonary edema. Later stages में दिखता है, but दिखता है. Usually first signs would be pedal edema in the patient, pitting type of pedal edema, hepatomegaly in the patient due to congestion of these organs. ठीक है, and increased JVP usually. ठीक है, and then definitely pulmonary edema can develop. Pulmonary edema is the earlier feature of left ventricular failure, and left ventricular failure में usually क्या होता है? The patient will have a pink frothy sputum usually due to pulmonary edema. ठीक है. That is a classical feature. Now he was diagnosed with CHF. Which of the following drug can increase longevity in this patient? What is longevity? Anybody? Very good. Increase the lifespan or survival chances of the patient. That is what is longevity. ठीक है? Or decrease the mortality. जब तो mortality कम करोगे तभी तो survival chances या longevity बढ़ेगी. So they are trying to ask you the drugs which will decrease the mortality in the patient or increase the survival in the patient. These are the drugs which are called as, which will lead to cardiac remodeling. These are the drugs which can lead to cardiac remodeling. क्यों cardiac remodeling करते हैं? Because due to prolonged hypertension, the patient would have left ventricular hypertrophy. So these drugs which usually lead to decrease in the left or the right ventricular hypertrophy. So they decrease the ventricular hypertrophy in this patient, okay? And therefore they will increase the survival or they will lead to a better prognosis in the patient. These are AB drugs, okay? A goes for 3 drugs. First is ACE inhibitors, your pill drugs, okay? Captopril, lisinopril, enalapril, all of this, okay? Then second A also goes for angiotensin receptor blockers, drugs like sartans, that is your valsartan, okay? Third A also goes for aldosterone antagonist. Aldosterone antagonists are drugs like potassium sparing diuretics like spironolactone or the another drug being eplerenone, okay? And last B goes for your beta blockers. So these are the drugs which will increase the survival chances in the patient, okay? So therefore, what is the best answer over here? Answer is option C, lisinopril. These lisinopril is the ACE inhibitor, angiotensin converting enzyme inhibitor. What are the ये सरकारी question again? ACE inhibitors के 2 important side effects. First is cough and angioedema. They are due to increase in which of the cytokines? Very good. They are due to increase in the levels of bradykinin, because ACE inhibitor, please remember the ACE enzyme, angiotensin converting enzyme, does not only convert angiotensin 1 to angiotensin 2, rather it is also responsible for degradation or metabolism of this bradykinin. But if we have inhibited this enzyme, then what will happen? There will be increased levels of bradykinin, and that can lead to symptoms like or side effects like cough and angioedema in the patient. No issues with this, anybody? But these cough and angioedema are not seen with drugs like angiotensin receptor blockers, like your sartan drugs. No issues till anybody? And this lisinopril. Furosemide, it is for edema. Please remember, it is for edema usually. It is the drug of choice. Okay? Not for increasing the longevity. Longevity, furosemide has no effect on the longevity or the survival outcome of the patient. Okay? They have furosemide नहीं देंगे. अगर edema के लिए पूछते हैं, the question was a previous year question in NEET PG where they asked which among the following is the drug of choice for edema in case of congestive heart failure. Rather, the mechanism of action of that drug was given, not the drug name directly. And what are the mechanism of action of loop diuretics of furosemide? They will inhibit which transporters? Sodium, potassium, 2-chloride transporters. They will inhibit sodium, potassium, 2-chloride transporters. In which part? Ascending limb of loop of Henle. No issues with this. And sodium chloride transporter inhibitors are thiazide, which usually act at which level of nephron? The DCT, distal convoluted tubule. ठीक है? अगर इसमें गड़बड़ी है, then definitely you need to work hard on yourself. Diuretics में तुम गड़बड़ी नहीं कर सकते हो. ठीक है? Sketch out, make a table, sketch out this diuretics multiple number of times, the group and their mechanism of action. ये पता होना ही चाहिए. ठीक है? That is the basic thing. No issues with this, anybody? So please remember, lisinopril का angioedema that has come a multiple number of times where they give you a swollen lip of the patient, okay? And they ask you which among the following drug is responsible for the side effect. In CHF, definitely, we also use this drug which is known as a cardiac glycoside. That is digitalis group of drugs known as digoxin. Okay, digitoxin has been withdrawn, but digoxin is still in use. And even if we use furosemide, that is your Lasix, that is loop diuretic. So please remember, which diuretics are used in CHF? Answer is loop diuretics. Which diuretics are used for hypertension? Answer is thiazides usually. No issue with this because loop diuretics are shorter acting and they're stronger agents, whereas thiazides are weaker and they're longer acting agents. No issues. Moving further, question number 21 now. A patient of chronic liver cirrhosis presents with ascites. Which of the following is the best diuretic to be used in this patient? So now please remember, so now I am coming to it. Now, in cases of ascites, in cases of cirrhosis, what usually happens in a patient of chronic liver disease or cirrhosis, the liver has been completely damaged. If the liver has been completely damaged, there would be decreased production of proteins, any plasma proteins, uska decreased production hoga. Okay, albumin means predominant one is albumin. And these proteins are mainly responsible for plasma oncotic pressure, which will pull the fluid towards the vessel. Okay? So this plasma oncotic pressure decreases, and therefore the patient will have extravasation of fluid, and that will lead to either edema in the patient or in peritoneal cavity aside. There would be formation of ascites. No issues with this. Yaad rakh lo. Apart from that, so here in cases of cirrhosis, usually, yaad rakh lo, the best diuretics which has shown the results, answer should be aldosterone antagonist. Okay, why? Because aldosterone also plays a role in cases of ascites. How? Because this aldosterone, please remember, whenever this aldosterone is increased, kab hoga aldosterone increase? When which system is activated? Renin, angiotensin, aldosterone system. When the RAS is activated due to low BP in this patient, what will happen? Due to this extravasation of fluid continuously into the peritoneal cavity, the patient will have low blood pressure. As the patient has a low BP, what will happen? This RAS would be activated. As soon as the RAS is activated, it will lead to increased levels of aldosterone. And what is the predominant action of aldosterone? It will cause retention of sodium and water, and it will lead to excretion of potassium, hydrogen ions, H plus ions. Okay, therefore it can cause hypokalemia and metabolic alkalosis or acidosis. H plus ions are acidic in nature. अगर वो फेंके जा रहे हैं, that means the patient will suffer from metabolic alkalosis. No issue with this. So one of the roles of predominant role is of aldosterone also. Therefore, in cases of ascites or edema due to cirrhosis, here aldosterone antagonists are the first choice to be given in the patient, and that is we will give either spironolactone or eplerenone. Spironolactone are avoided in males because it leads to gynecomastia. Therefore, in males we use a drug that is known as eplerenone. No issues with this. If I would have said it is a patient of CHF and इसमें कौन सा best diuretic होता है, then your answer should have been furosemide. No issues with this, anybody? याद रख लो, ठीक है. Triamterene is which group? It is also a potassium sparing diuretic. यहाँ दूसरा reason why we are using aldosterone antagonist, because this aldosterone is also leading to hypokalemia in the patient. Therefore, we will use potassium sparing diuretic to increase the levels of potassium in the plasma. ठीक है, that is the second benefit that we get. Triamterene कौन से channels पे act करता है? This is a ENaC blocker or a ENaC inhibitor. epithelial sodium channel blocker है ये, ठीक है. Triamterene और amiloride, these are also potassium sparing diuretics. कोई दिक्कत नहीं है इसमें. आगे बढ़ते हैं अभी. Question number 22. Which of the following is the action of dopamine at low doses? So dopamine usually it acts at three important receptors. सबसे at low doses it acts on the D1 receptors, then on the B1 receptors, and then on the alpha 1 receptors. Okay, in D1 receptors it usually acts at doses less than 2 microgram per kg. Okay, whereas per minute. Then beta 1 per usually it acts at doses between 2 to 10 micrograms, and at alpha 1 it acts at doses more than 10 micrograms. No issues with this. When it acts on D1 receptors at low doses, that will increase the renal blood flow, because these D1 receptors are present on the blood vessels of your kidney, and therefore as these D1 receptors are stimulated, there is vasodilation in the kidneys that will increase the renal blood flow. This beta 1 receptors, when they are stimulated, that will increase the chronotropic action of heart. Chronotropy is nothing but increase in the heart rate. Increase in heart rate is what is called as chronotropy. Okay, so that would lead to increase the heart rate of the patient. And when alpha 1 receptors are stimulated, that will lead to vasoconstriction. No issues with this, anybody? So this is important. Which is the inotrope? So please remember, dopamine is inotrope. Inotrope मतलब क्या होता है? Very good. Inotropic action of heart is nothing but increase contractility of the heart. So the drugs which can increase contractility of the heart to increase the cardiac output, these are called as inotropes usually. And one of the inotropes is dopamine usually. Okay, that is the funda. Okay, therefore It is used in cases of CHF as well. Now, in case the other inotropes that you need to remember, can anybody tell which is the inotrope which only acts on beta-1 receptors? Very good. The one which only acts selectively at the beta-1 receptors, answer is dobutamine. Please remember this. Okay. And the one which acts on all the receptors is adrenaline. Not adrenaline, it is adrenaline or epinephrine. कोई दिक्कत नहीं है इसमें. ठीक है, तो याद रखो ये बात. Question number 23 now. You notice your senior performing a vagal maneuver. Vagal maneuver is usually done beneath the angle of mandible. Okay, and we press this your internal carotid artery for some time. Okay, and the internal jugular vein for some time, and then we release it. No issues with this, anybody? Or we do a carotid massage in this patient. Okay, as you do a carotid sinus massage in this patient, what will happen? Which nerve would be stimulated? The vagus nerve is stimulated. And if the vagus nerve is stimulated, it would lead to overactivation of parasympathetic action or sympathetic action on heart. It would lead to a overactivation of parasympathetic activity. It causes a parasympathetic overactivation. And parasympathetic overactivation on heart will lead to decrease in heart rate or increase in heart rate. It will lead to decrease in heart rate of the patient, decreasing the oxygen demand of the heart. Okay, and therefore giving a better outcome. No issues till anybody? And therefore, as the heart rate is decreased, therefore it is used in case of arrhythmia. Therefore, this carotid sinus massage, as it decreases the heart rate, therefore it is used in case of tachyarrhythmia, where the heart rate is very, very high. Okay? So, usually not in case of ventricular arrhythmia, only in cases of supraventricular tachycardia, that is your paroxysmal supraventricular tachycardia or PSVT. Why? Because first of all, it decreases the heart rate. Second, it also decreases the impulses going from the SA node to the AV node. Okay, so SA node से अगर AV node में जाने वाली है, AV node से आगे जाने वाले impulses को अगर वो कम कर रहा है, definitely the ventricular rate of the patient is decreased. Okay, that is the reason. No issues with this, anybody? Now, he was doing a vagal maneuver in a stable patient with PSVT. Which of the following muscarinic receptors mediate the therapeutic effect of this maneuver? हार्ट पे कौन से रिसेप्टर्स होते हैं उतना ही पूछना था हमको. दैट इज योर M2 receptors. ठीक है. whereas the other types of receptors were other types of cholinergic receptor. M मैंने पूरा डिस्कस कर दिया. other type were N and NM. NN were present at the level of ganglia, whereas NM were present at the level of neuromuscular junction. ठीक है. alpha 1 are present at the level of blood vessels and alpha 2 at the level of presynaptic neurons, and therefore they act as brakes whenever they are stimulated. ठीक है. They will stop the adrenergic activity rather. Beta 1 कितना हार्ट है तुम्हारे पास? एक. तो beta 1 on the heart. कितनी lungs है तुम्हारे पास? दो. So lungs या बहुत सारी places like your bronchus, kidneys, everywhere you will have this beta 2 receptors, except in the JG cells of kidneys. Okay, there we will have the beta 1 receptors in the JG cells of kidneys, which are responsible for secretion of renin, and therefore whenever the beta 1 receptors in the JG cells are stimulated, that causes renin secretion. So if they ask you which is the renin release inhibitor, यही पता मुझे. बीटा ब्लॉकर. रेनिन रिलीज का इनहिबिटर, आंसर इज बीटा ब्लॉकर. रेनिन का इनहिबिटर, आंसर इज किरण ड्रग्स, एलिस किरण, रामी किरण. नो इश्यूज विद दिस एनीबॉडी? सो प्लीज रिमेंबर, रेनिन का रिलीज कौन रोकता है? बीटा ब्लॉकर्स, बिकॉज़ दिस बीटा 1 इज इनहिबिटेड, देयरफॉर रेनिन का सिक्रीशन ही नहीं होगा. तो रेनिन रिलीज इनहिबिटर्स आर बीटा ब्लॉकर्स, बट रेनिन इनहिबिटर जब रेनिन सिक्रीट हो चुका है उसके अगेंस्ट एंटागोनिज्म कौन करेगा? तो Kiran drugs, that is Alice Kiran, Remy Kiran. This was a question in FMG exam. ठीक है, अगस्त में भी आ चुका है, उसके बाद और एक बार भी आ चुका है. ठीक है, so direct renin inhibitors, answer should be Kiran drugs, but renin release inhibitors, answer should be beta blockers. कोई दिक्कत नहीं है इसमें. And beta 3 receptors are present at the level of adipose tissue. हाँ बोलो. Increases renin indirectly, usually मतलब due to stimulation. अगर जब लो बीपी होता है ना यूजुअली, तो उसकी वजह से अगर रेनिन सिक्रीशन बढ़ा देते हो तो उसको यूजुअली बोला जाता है इनडायरेक्ट रेनिन को बढ़ाना यूजुअली. ठीक है. जब तुम कोई ड्रग होगी जो वेसोडाइलेट करेगी और बीपी को कम करेगी, तो उसकी वजह से क्या हो जाएगा? तुम्हारा रास एक्टिवेट होगा और तब जाके रेनिन बढ़ेगा. तो सच वेसोडाइलेटर्स व्हिच विल increase the renin indirectly. These are what are called as your drugs which will increase the levels of renin, but indirectly, not directly. Directly वो drugs होंगी जो beta 1 को stimulate करेगी. Indirectly वो drugs होंगी जो vasodilation करेगी. ठीक है? No issues with this anybody? So यहाँ पे PSVT में carotid sinus massage क्यों कर रहे थे? क्या क्यों कर रहे थे vagal manure? Because the patient was a stable patient. Because the patient was a stable patient. If the patient is not a stable one, that means his hemodynamic profile is deteriorating. अगर उसका BP fall हो रहा है, तो इस condition में क्या करते हैं अपन? Very good. Cardioversion. Synchronized or non-synchronized? Synchronized. क्योंकि इसमें peak दिखता है. Okay, therefore synchronized cardioversion in case of unstable PSVT. And in stable PSVT, first line manure अगर वो पूछेंगे, answer should be carotid sinus massage. Drug पूछेंगे, then answer should be adenosine, which is the shortest acting anti-arrhythmic drug. Half life less than even 10 seconds. ठीक है, आगे बढ़ते हैं. Question number 24. An elderly male patient, a known case of COPD, chronic obstructive pulmonary disease, complains of increased urinary frequency, hesitancy and urinary retention. कब होगा? When the urethra of the patient is narrowed down. क्यों? Because it is being applied pressure from a hypertrophied prostate. So एक hypertrophied prostate है which is compressing the urethra, and therefore the urine is not able to come out properly, and therefore the patient is having urinary symptoms like urinary frequency, hesitancy, that means difficulty in initiation of urine, and urinary retention. ठीक है? So these are features of benign prostatic hyperplasia, which is usually seen in which patient? Elderly males. The patient symptoms can be relieved with the help of which drug? Now, आ रहा उस पर. ठीक है, एक करके करते हैं. Bithanicol की अगर मैं बात करूं, please remember Bithanicol is usually a drug which is used in cases of atonic bladder. Okay, it is used in cases of atonic bladder. It acts on which receptors? It is the agonist at the M3 receptors. But what is the problem with Bithanicol? Bithanicol will also non-selectively act on the receptors, that is the M3 receptors in the bronchus, and that will cause bronchoconstriction. तुम्हारा patient कौन है? COPD. He is having respiratory distress. So these are absolutely contraindicated in a COPD or an asthmatic patient. Same goes for methacholine. Methacholine also non-selectively acts on the bronchus M3 receptors, and therefore that can also cause bronchoconstriction. Therefore, again, methacholine cannot be used. Okay, no issues with this, anybody? That is the thing. Now in BPH, if they ask you which is the best drug, the drug of choice for benign prostatic hyperplasia, there are alpha-1 receptors. Okay? So alpha-1 blockers can be used. But what is the problem with alpha-1 blockers? These will block alpha-1A as well as alpha-1B receptors. If the alpha-1B receptors on the vessels are blocked, that can cause vasodilation. That can cause vasodilation. Blockage है ना, तो vasodilation होगा, and that can lead to which type of hypotension? Postural hypotension, which is a side effect associated usually with alpha-1 blockers, a non-selective alpha-1 blockers, drugs like prazosin or terazosin. So zosin drugs जो होते तुम्हारे, these are non-selective alpha-1 blockers. They will block alpha-1A as well as alpha-1B. Alpha-1A is located on prostatic urethra. Dilatation होगा, urinary frequency अच्छी हो जाएगी, urinary symptoms could be relieved, but at the same time it will also cause vasodilation leading to postural hypotension. ठीक है? Therefore, prazosin and other zosins are usually avoided in the patients who have a normal blood pressure. If the patient has a normal blood pressure, we will only actually use the drugs which will only block your alpha-1A receptors. Okay, selectively block the alpha-1A receptors. So drug of choice, if I ask you in a normotensive patient, answer should be alpha-1A receptors like tamsulosin or silodosin like drugs. Answer should be silodosin. Because did I mention the patient was hypertensive? If I would have mentioned the patient was hypertensive, तो उसमें दोनों फायदे होते हैं. एक तो यूरिनरी फ्रीक्वेंसी भी बढ़ जाती, साथ साथ ब्लड प्रेशर भी कम हो जाता. Then in hypertensive patient along with BPH, the drug of choice can be prazosin, but not in a normotensive patient जिसका BP low है, because that patient can suffer from postural hypotension. What is the drug of choice for postural hypotension? Very good. The drug of choice for postural hypotension is midodrine. चलो आगे. Question number 25 now. A patient with heart disease presents to the emergency with severe vomiting and blurry vision and mentions that he sees a greenish yellow tinge all over all the objects. ठीक है? Greenish yellow tinge over all the objects. मतलब he is having a yellow vision, and yellow vision is what is called as xanthopsia, and the xanthopsia is a side effect of. Very good. It is a side effect of digoxin. So xanthopsia or yellow vision is a side effect of a digitalis or cardiac glycoside known as digoxin. Okay, please remember. And we know most common side effect क्या होता है digoxin का? Most common side effect? Very good. Shabash. Nausea and vomiting. But arrhythmias भी हो सकते हैं digoxin की वजह से. ठीक है? तो most common अगर आता है तो please mark nausea and vomiting. ये गलती करी है लोगों ने, उसमें arrhythmia mark करके आ गए थे. ठीक है? So it is nausea and vomiting. Arrhythmias can be seen. And अगर वो पूछते हैं arrhythmia, तो which type of arrhythmia is most common? Most common digoxin-induced arrhythmia is ventricular bigeminy. And which is the most characteristic arrhythmia? Non-paroxysmal atrial tachycardia along with AV block. कोई दिक्कत नहीं है. This is the most characteristic or the most specific arrhythmia due to digoxin toxicity. ठीक है? So arrhythmia की भी होती है, xanthopsia की भी risk है, and nausea vomiting की भी है. He experiences palpitations, breathlessness and collapses. That is suggestive of arrhythmia in the patient. Okay, palpitations, breathlessness, collapses. That is suggestive of a tachyarrhythmia. His ECG is given below, which confirms which arrhythmia is suffering from. Very good. You can see it is only a fibrillating wave. That means the ventricles are only fibrillating. They are not contracting properly. Because they are not contracting properly, a proper QRS complex is not formed. ठीक है? So it is only ventricular fibrillation. No issues with this, anybody? So which would be the most appropriate drug for immediate management? यहाँ पे आ रहा हूँ मैं. यहाँ पे the best answer would have been, as it is ventricular fibrillation, the best answer is always and always DC cardioversion. The answer is always DC cardioversion. ठीक है? In VT you can see, अगर VT में patient if he is stable, that means his BP and that is not falling. Okay, then you can go for drugs. But if the patient is unstable, again in cases of unstable VT also the treatment is again DC cardioversion. If I talk about stable VT, यहाँ पे तुम क्या कर सकते हो? Amiodarone is done for chemical cardioversion. No issues with this. Amiodarone can be given. Lignocaine can be used, but better drug is amiodarone to be used. No issues with this. So better answer यहाँ पे होना चाहिए था DC cardioversion, because if the ventricles are only fibrillating, blood pressure तो उसका होगा ही नहीं. Almost the patient would be collapsing. ठीक है? But as that is not an option, so the second best answer that we need to mark as a drug, it is only lignocaine. हाँ, drug of choice ही है, but it is not in an unstable patient. यहाँ पे ECG does not confirm it is a stable patient. ECG ventricular fibrillation का है, मतलब the patient is definitely unstable. Okay, blood pressure उसका 40 के आसपास होगा. हाँ, बट वही मैं बता रहा हूँ, टॉक्सिसिटी के लिए दिया है. टॉक्सिसिटी के लिए वैसे बेस्ट ड्रग दिया उन्होंने डिजीबाई. ठीक है, ऐसा है. बट अगर वेंट्रिकुलर अरिथमियास के लिए पूछोगे तो डेफिनेटली लिग्नोकेन या फेनिटोइन ऑप्शंस हैं. बट अगर पेशेंट अनस्टेबल है तो कोई भी टाइप का हो, digoxin की वजह से हो, नहीं तो किसी भी टाइप से हो, DC cardioversion is the first. ठीक है? Along with that, after that we can start lignocaine to the patient, but पहले नहीं. ठीक है? हाँ, Procainamide is not used. Procainamide is usually used in cases of WPDF syndrome वगैरह. ठीक है? यहाँ पे नहीं यूज करते उसको. Now digoxin induced arrhythmias अगर बात करते हैं वो, if they ask you about digoxin induced arrhythmias, drug of choice is definitely lignocaine. Digoxin induced arrhythmias की अगर मैं बात करूँ, drug of choice is definitely lignocaine. Okay, which is a sodium channel blocker. Apart from that, we can also give phenytoin to the patient. अगर ये भी option नहीं होगा. But recent NEET PG question, lignocaine and phenytoin are only used for tachyarrhythmia. जब तक heart rate ज़्यादा है, in such kind of arrhythmias where the heart rate is too much, only in these arrhythmias definitely we can use these lignocaine or phenytoin. But इस बार का जो नीट पीजी क्वेश्चन था, in that they did not give a tachyarrhythmia. Rather, they said that the patient was having a complete heart block, which is a bradyarrhythmia. Okay, the heart rate of the patient given was around 54 per minute. So in this condition, please remember, lignocaine, phenytoin or DC cardioversion, any of this would not be done in the patient. Okay, any of this would not be done. Blood pressure was not mentioned. And anyways, even if it was an unstable patient, we would not have more. Okay, but if it is a bradyarrhythmia, DC cardioversion is not done. Bradyarrhythmia mein, the drug of choice that we have given an option was a option mein bata raha hu, it was only digibind. Atropine definitely can use to increase the heart rate of the patient, but the drug which is used in digoxin toxicity, it is the digibind, which is an antibody, okay, which will bind to the digoxin and will decrease its toxicity. No issue with this digibind. Rather, उन्होंने कैसा दिया था उसको? They wrote digibind as something like this. ठीक है? So that was the first option. No issues with this. So antibody है ना वो. So digibind is nothing but an antibody. ठीक है? ऐसे दिया था उन्होंने. ठीक है? Question number 26 now. A patient was stung by a bee and now presents to the emergency room with rash all over the body, hypotension and difficulty in breathing. Classical signs of which shock in the patient? Anaphylactic shock. And what is the drug of anaphylactic? Definitely adrenaline. What is the dilution which is given? 1:1000. By which route? 0.5 ml 1:1000 dilution. That means तुम्हें dilute करना ही नहीं है. Ampule आधी ही 1:1000 की है. Therefore, you will lower the adrenaline directly and give it via the intramuscular route. 1:1000 dilution, 1:10,000 dilution तब करना पड़ेगा when you need to give it by the IV route. When it need to give it by the IV route, and that is usually given in cases of cardiac arrest during a CPR. ठीक है? जब तुम CPR कर रहे हो, basic resuscitation चल रहा है, at that time if the patient is having, दोनों में दे सकते हो, whether it is a shockable rhythm or an unshockable rhythm. But shockable rhythm होगी तो पहला treatment definitely होगा DC cardioversion, and then after 3 steps we will go for IV adrenaline. But if it is a non-shockable rhythm is something like asystole or pulseless electrical activity. इसमें the first treatment option after CPR would be adrenaline. इसमें DC cardioversion नहीं करते हो until and unless the rhythm is shockable. ठीक है? No issues till anybody got what is adrenaline? तो कम से कम ये याद रखिएगा. Question number 27. What is the drug of choice for shock plus oliguria? Dopamine. Whereas in cases of septic shock or cardiogenic shock, the better drug to be given is NORAD, noradrenaline we give. Septic shock or cardiogenic shock. No issues with this anybody? Reason being, दो विटामिन नहीं देते. दो विटामिन बस हार्ट रेट बढ़ाएगी और कार्डियोजेनिक शॉक में भी मैं बता रहा हूँ ना, बेटर इज नॉरएड्रेनालिन तुम्हारा. द रीजन बीइंग, रीजन दे रहा हूँ, रुक जा, भड़क मत इतना. ठीक है? नॉरएड्रेनालिन, व्हाट इज द एक्चुअल इफेक्ट ऑफ नॉरएड्रेनालिन? ये फाइनल इफेक्ट, नेट इफेक्ट क्या करेगा? हार्ट रेट को बढ़ाएगा, हार्ट रेट को कम करेगा. बीपी बढ़ाएगा, हार्ट रेट पे बताऊं मुझे असर फाइनल. हार्ट रेट को बढ़ाएगा. दिस विल आल्सो इंक्रीज द ब्लड प्रेशर. तो तुम ही बताओ अभी ये दोनों चीजें अच्छी कर रहा है शॉक में, तो क्या करना चाहिए? हार्ट रेट is one of the factors on which the cardiac output is dependent. तो हार्ट रेट भी बढ़ा रहा है, बीपी भी बढ़ा रहा है, तो बेटर ड्रग इज नॉरएड्रेनालिन. ठीक है? हाँ, ओके, हाँ, सॉरी. एड्रेनालिन यूजुअली इंक्रीजेस एंड usually decreases. कार्डियोजेनिक शॉक में का एप्लीकेशन बताता हूँ. सेप्टिक शॉक में डेफिनेटली, सेप्टिक शॉक में you can give noradrenaline, but in cardiogenic shock heart rate कम क्यों करना होता है? Now cardiogenic shock मतलब the heart is not able to pump properly. You need to make the heart to pump properly. That means increase the कॉन्ट्रैक्टिलिटी ऑफ द हार्ट। तो कॉन्ट्रैक्टिलिटी ऑफ हार्ट बढ़ाते हो, बट एट द सेम टाइम जब हार्ट रेट कम होता है, यूजुअली हार्ट रेट कम जब होगा तब कॉन्ट्रैक्टिलिटी ढंग से हो पाती है। जब हार्ट रेट कोई ड्रग बढ़ा दिया है, इट इज कॉजिंग इनएफेक्टिव कॉन्ट्रैक्शन। एज द हार्ट रेट डिक्रीजेस, इट विल यूजुअली कार्डियोजेनिक शॉक कब होता है, जिसमें अरिथमिया, ठीक है। तो अरिथमिया जब होता है तो द हार्ट इज नॉट एबल टू पंप प्रॉपर्ली एंड दैट कैन एंड ऑफ द पेशेंट इन केसेस ऑफ शॉक, ठीक है। क्योंकि हार्ट में अरिथमिया है, हार्ट रेट बहुत ज्यादा है, तो हार्ट बस ऐसे चल रहा है। अगर हार्ट बस ऐसे चल रहा है तो क्या हो रहा है, कार्डियक आउटपुट कम है। तो अगर तुम कार्डियक आउटपुट भी बढ़ा रहे हो, उसके साथ साथ हार्ट रेट भी कम कर रहे हो, देयरफॉर द बेटर ट्रीटमेंट इज नॉरएड्रेनालिन। कोई दिक्कत नहीं है। ऑन द अदर हैंड, डोपिडामिन इंक्रीजेस द हार्ट रेट एंड देयरफॉर इट कैन वर्सन द स्टेटस ऑफ द पेशेंट इफ द कार्डियोजेनिक शॉक इज ड्यू टू सम अरिथमियाज इन द पेशेंट। कोई दिक्कत नहीं है इसमें। सो दैट इज द फाइनल एस्पेक्ट, ठीक है। क्वेश्चन नंबर 27 की अगर मैं बात करूं, a male patient who was recently suffering from apathy and was depressed. Apathy is lack of interest in any activity, okay, and was depressed, and early morning insomnia was also there to the patient. That means the person is waking up 2 hours of the normal awakening time, ठीक है। अगर वो पहले 7 बजे उठता था, अभी वो 5 बजे उठ के खड़ा हो जाता है, ठीक है। He was started on escitalopram. Escitalopram belongs to which group of drugs? SSRIs, that is selective serotonin reuptake inhibitors, ठीक है। It will only inhibit the reuptake of serotonin, thereby increasing the levels of serotonin in the synapse. As it increases the levels of serotonin in the synapse, that will help in overcoming क्या है diagnosis? The patient is having depression over here. That is the reason why it will help in overcoming depression. याद रखना, in cases of depression, psychosis में the most important monoamine that was responsible was dopamine, but for depression the most important monoamine that is responsible is serotonin, okay, followed by noradrenaline and followed by dopamine, okay. Therefore the drugs which will block the reuptake of serotonin and increase the levels of serotonin would be used in cases of depression, okay. SSRIs will only act on serotonin and therefore these are used in cases of mild to moderate depression. So drug of choice for mild to moderate depression are SSRIs, but the drugs which can block serotonin as well as noradrenaline reuptake, it will increase levels of both. These would be used in conditions of severe depression. And which are the drugs which are serotonin, norepinephrine reuptake inhibitors? The drug which was asked was venlafaxine. They gave venlafaxine belongs to which group? One of the option was SNRI. Okay? So when the drugs are SNRI, serotonin, norepinephrine reuptake inhibitors, drugs like venlafaxine, desvenlafaxine, milnacipran, levomilnacipran, and important one. ये exception क्यों मैं याद दिला रहा हूँ? Because all the statins are usually SSRIs except duloxetine. This duloxetine is a SNRI. तो ये exception याद रखना जरूरी है। तुम नहीं तो सब statins SSRI याद रख लोगे तो नहीं चलेगा, ठीक है। तो one of the statin is usually SNRI and that is duloxetine. बाकी जितने भी है तुम्हारे, all the statins usually they are SSRIs, dapaxetin, fluoxetine, ठीक है। All of these are SSRIs, ठीक है। कोई दिक्कत नहीं है। Just like that, SSRIs are citalopram, escitalopram, all of these as well, ठीक है। Fluoxamine, all of these. तो अगर SSRI दे दिया था पेशेंट को, which of the following adverse effect cannot be explained by this drug? कौन सा साइड इफेक्ट नहीं है SSRI? Very good. Delayed ejaculation is one of the side effect of SSRI, and therefore it is used in cases of premature ejaculation when the ejaculation occurs within 1 minute. Okay, so in this condition, SSRIs are used for treatment. Rather, they are the drug of choice. And which is the drug? Dapaxetin. The drug of choice for premature ejaculation is dapaxetin. No issues with this, anybody? Nausea. Yes, it is one of the common, rather the most common side effect, okay, of SSRIs. Vivid dreams. Yes, the patient will have real and vivid dreams usually, okay, and they would be very clear. Vivid का मतलब होता है बहुत clear होंगे, तो वो तुम्हें अच्छे से describe करेगा कि ऐसी अप्सरा आई थी मेरे सपने में, ठीक है। तो मतलब the vivid dreams would be there. Cialorrhea is not a side effect which is associated with SSRI. Rather, cialorrhea, that means excessive salivation, and this excessive salivation is a side effect which is associated with atypical antipsychotics. And the most important drug which causes cialorrhea is क्लोजापिन. आंसर इज क्लोजापिन. कोई दिक्कत नहीं है इसमें, ठीक है, याद रखो. Shall I move further? ये severe depression वाला recent question है guys. Please remember SNR as like venlafaxine. Other TCS can also be used. And what is the important side effect of TCS? जो recent में था, TCS tricyclic antidepressant drugs like imipramine, clomipramine, amitriptyline, nortriptyline. They will lead to metabolic acidosis. That was given in the recent FMG June 2022. Okay, TCS can lead to metabolic acidosis, and therefore the drug which is used for treatment is sodium bicarbonate. Soda bicarbonate देते हो patients को. In TCA toxicity, one of the important side effect of TCA is metabolic acidosis. Even they can cause seizures. No issues with this. Question number 28. A female patient on lithium therapy for bipolar disorder for 6 months. She was fasting for few days due to some religious reasons and was presented with vomiting, seizures, coarse tremors, confusion, and weakness of limbs. Which of the following investigation is most accurate to diagnose a condition? So now, if the patient is fasting for some days and she's on lithium therapy, usually there would be high chances of lithium toxicity in the patient. Okay? Lithium toxicity, as it is a very narrow therapeutic index drug. Okay? And lithium toxicity के ही features क्या होते हैं? LI for increase in leukocytes. That is what is called as leukocytosis. So it causes leukocytosis. Therefore, it can be used in conditions of neutropenia. Mainly, it increases the neutrophil levels. So neutropenia में, ठीक है? He usually goes for the most common side effect of lithium. Tremors. Most common side effect of lithium toxicity answer is tremors. H goes for hypothyroidism. H goes for hypothyroidism. IU goes for increase in urination. That means it leads to polyuria in the patient. And M usually goes for it should be avoided in mothers because it leads to a teratogenic side effect known as Epstein's anomaly. Sarkari question. Lithium in pregnancy can lead to Epstein's anomaly, a box-shaped heart in the child. No issues with this. What is the therapeutic level of lithium? Lithium is the drug of choice for? It is the drug of choice for bipolar disorder. It is the drug of choice for bipolar disorder. Okay, please remember this. Okay. Why not in cases of acute mania? याद रख लो. Acute mania में अगर तुम lithium दे दोगे patient को, it is a mood stabilizer. It will not settle down the patient. तुम्हें 2-4 लगा देगा. ठीक है, mania वाला patient. Therefore, the primary aim in cases of acute mania is not to stabilize his mood, rather to settle him down, rather to sedate him. And therefore, the drug of choice would be very good. Atypical antipsychotics can be given drugs like olanzapine, or we can even give drugs like benzodiazepines. ठीक है? Along with lithium definitely, but the better drug, अगर एक drug of choice mark करनी है acute mania में, answer should be atypical antipsychotics or benzodiazepines. No issues with this anybody? If they ask you bipolar disorder, definitely your answer should be lithium. And if they ask you for maintenance of mania, again the answer should be lithium. Maintenance of mania मतलब mania control हो चुका है. Now अभी क्या दोगे? Now your answer should be maintenance of mania. ठीक है? Maintenance of mania, that is lithium. No issues with this anybody? That is clear. Now what is the therapeutic level of lithium for maintenance? Very good. 0.5 to 0.8 milliequivalent. ये question आ चुके हैं यार. 0.5 to 0.8 milliequivalents per liter. What is the therapeutic level of lithium in cases of acute mania? Very good. The dose in cases of acute mania, or the therapeutic level, it should be maintained between 1.8 to 1.2 milliequivalents per liter. Okay? And when it exceeds more than 2, that can cause toxicity of lithium. कोई दिक्कत नहीं है इसमें. So, if it is lithium toxicity, go for serum lithium levels in the patient. All of these, vomiting, seizures, okay, coarse tremors, confusion, all of these are features of lithium toxicity itself. Question number 29. Question number 29. A US-based businessman comes to you who is traveling to an malaria endemic zone. So you prescribe tablet mefloquine to him for prophylaxis. Prophylaxis means prevention. With its consumption due to high protein binding, what would you expect? Agar if some drug is having high protein binding, plasma, proteins ka hote hai inside the plasma. If the drug has high protein binding, it will remain inside the plasma mainly. And the volume of distribution of this drug would be low. Okay, that is the funda. Okay? And therefore, the filtration of this drug would also be low. Why? Because it is bound to plasma proteins, and proteins cannot be filtered out from the kidneys. Free form of drug is eliminated or aspirated out during filtration, but not the plasma protein bound form. Or jo drug which has high plasma protein binding will have low volume of distribution and low filtration or clearance from the kidneys. Okay? So if the drug has high protein binding like mefloquine or chloroquine, highest, okay, so highest is with chloroquine. Then option A says decrease glomerular filtration. होगा या नहीं होगा? Decrease glomerular filtration होगा या नहीं होगा? High volume of distribution, rather there would be low volume of distribution because it is binding to plasma protein and it remains in the plasma, not going inside the tissue. Therefore, there would be low volume of distribution, not high. Lesser duration of action? No, because it is binding to plasma protein. It has not been excreted out. If it has not been excreted out, it is staying in the plasma for a longer duration of time. Therefore, there would be a increased duration of action. And lesser drug interactions? No, usually there would be increased drug interactions because it is staying in the plasma itself. Okay? So here the best answer would be decreased glomerular filtration. कोई दिक्कत नहीं है इसमें. Question number 30. A 55-year-old patient comes with palpitations and headache. On examination, the blood pressure was 170 by 90 mm of Hg. Heart rate is 98 beats per minute and respiratory rate is 12 per minute. That is on the lower side at least. Not completely low because 12 to 20 is fine, but on the lower side. Okay, blood pressure is high. That is hypertension. On history taking, he takes insulin for diabetes and he has 2 hypoglycemic attacks prior. Which of the following drug is better avoided in this patient? So if a patient is a diabetic individual, usually, and if he is on insulin, what can happen? Insulin is the drug which has highest risk of which side effect? Hypoglycemia, followed by sulfonylureas that we discussed already. Okay? So insulin has the highest risk of hypoglycemia, low blood sugar levels. Okay, and if a patient is taking a beta blocker, what can happen? If a patient is taking beta blocker, there would be inhibition of these beta receptors. Okay, these beta receptors are usually stimulated. These beta receptors are usually stimulated during hypoglycemia, and once this beta 1 receptors are stimulated, that will cause warning symptoms. That will cause warning symptoms like palpitations, tremors, tachycardia. Okay, so sweating, all of these, diaphoresis, palpitations, tremors, tachycardia, due to beta 1 stimulation, and the patient gets to know कि okay मुझे hypoglycemia हो रहा है, मुझे ये symptoms आ रहे हैं, तो मुझे glucose खा लेना चाहिए, ठीक है? But if beta blocker is given to a patient, will this symptoms appear? No, this symptoms will not occur, and that is what is called as masking of warning symptoms. This is known as masking of warning symptoms. Second, in cases of hypoglycemia, the beta receptors in the liver are also activated, and that causes increased gluconeogenesis, increased glycogenolysis, and that again increases the blood glucose levels. Again, if blood beta blockers are given to the patient, this action would be blocked. There would not be increased gluconeogenesis, increased glycogenolysis. So reversal of hypoglycemia is not seen. So reversal of hypoglycemia is also blocked in the patient. Okay? So if beta blockers are given in a diabetic patient, first of all, there would be masking of warning symptoms, and second, there would be no reversal of hypoglycemia. Okay? So that is the reason why we try to avoid, though metoprolol is a beta 1 selective beta blocker, then also we try to avoid any beta blocker in a patient of diabetes mellitus. Okay? Question number 31. A 30-year-old female presents with severe unilateral pulsatile headache. She had such episodes 3 to 4 times since last year. The episodic disease hai. All investigations were found to be normal. The doctor prescribed the newly approved drug that acts by stimulating the 5-HT1F receptors. मैंने already बता दिया. Diagnosis is nothing but migraine again. And I told you 5-HT1B1 agonist. Those either are your triptans or ergot or amines or ergot derivatives. Whereas 5-HT1F receptors are 5-HT1F receptor agonists are ditan drugs like lasmiditan. Okay, here answer is option B, lasmiditan. Please remember this galcanezumab or praminezumab. These drugs are usually used. These are monoclonal antibodies used for prevention of migraine. Okay, erenumab भी use होती है. Okay, erenumab भी use होती है. Galcanezumab, praminezumab, and erenumab. These are generally used for prevention of migraine. These are the new monoclonal antibodies. But the drug of choice for prevention of migraine, we know it is propranolol. It is propranolol. And what was the main culprit behind it? The vasodilation was caused by a peptide known as CGRP, calcitonin gene-related peptide. So CGRP release can be inhibited by triptans, ठीक है? But CGRP अगर release हो भी जाता है, so a CGRP antagonist can be given to the patient, and that is what is called as olcegipant. This is what is known as olcegipant. ठीक है? So these are the usual drugs used in case of migraine. ठीक है? No issues with this, anybody? Even in prevention of migraine, we can also use your tricyclic antidepressants like imipramine, or we can even use calcium channel blockers, drugs like flunarizine. Okay, drugs like flunarizine can be used. No issues with this, anybody? So all of this you need to remember. Okay? Question number 32. Which among the following drug inhibits PCSK9? Question of NEET PG 2022. So it is a monoclonal antibody which inhibits this PCSK9, that is pre-protein converting subterism kexin type 9. ठीक है? बस PCSK9 याद रख लो. This is a protein. ये क्या करेगा usually? This is a protein which usually causes LDL receptor degradation. These LDL receptors are located on the liver. तो जो liver पे LDL receptors होते हैं, ये क्या करते हैं? They take up, please remember, they take up cholesterol from blood. These LDL receptors usually take up cholesterol from blood usually, ठीक है? But if this LDL receptors are degraded, what can happen? There would be increased levels of blood cholesterol. There would be increased levels of blood cholesterol, and that can worsen hyperlipidemia or dyslipidemia in a patient. Therefore, in case of hyperlipidemia or dyslipidemia, जो नई drug निकाली गई, it was to inhibit this PCSK itself, so the LDL receptors are not degraded, and therefore there would be increased levels of LDL, which will increase the uptake of cholesterol from the blood, thereby decreasing the blood cholesterol levels, and therefore helping in hyper or dyslipidemia. Okay, and this was a monoclonal antibody known as evolocumab, and the second drug is known as alirocumab. No issues with this. Statins were inhibiting which enzyme? HMG coenzyme A reductase. Cholestyramine, it leads to inhibition of, it will lead to inhibition of the enterohepatic cycle. Okay, it will lead to inhibition of the enterohepatic cycle. Therefore, more and more bile acids would be excreted out. More and more bile acids would be excreted out from the urine. No issues with this, anybody? Okay, certolizumab is not over here. It's a monoclonal antibody used in cases of colorectal cancers. Now, kya? Question number 33 now. A 68-year-old male known case of chronic kidney disease, CKD, requiring twice every week dialysis, was scheduled for AV grafting in right arm. He was given injectable anticoagulants post the procedure. Injectable anticoagulants which we generally give is nothing but heparin. Okay, low molecular weight heparin is usually given like enoxaparin, dalteparin, something like that. Post the procedure, but was started on an oral drug at discharge. Q? Because after discharge, the patient cannot get injectables every day. Na? So for maintenance therapy, maintenance doses, we will give a oral drug to the patient. The doctor was advised to undergo monitoring with INR, that is International Normalized Ratio. Which of the following drug is prescribed to the patient? The drug which will require monitoring, close monitoring with prothrombin time or INR. The answer should be an oral anticoagulant drug, and that is known as warfarin. Okay? Why? Because warfarin is a vitamin K antagonist. As it is a vitamin K antagonist, it will lead to decrease in the levels of clotting factors. Which one? 2, 7, 9, and 10. Because this vitamin K causes activation of these clotting factors 2, 7, 9, and 10. So इनकी level कम हो जाएगी. And the main one is which is affected is the clotting factor 7, which is a part of which pathway? Extrinsic pathway of coagulation. And whenever extrinsic pathway of coagulation is affected, which time is prolonged? The PT or the INR is prolonged in the patient. Okay? Whereas heparin mainly, it affects which pathway? It inhibits which clotting factors? Factor 2A and factor 10A, but it does not directly inhibit this factor 2A and 10A. So rather it forms a complex with antithrombin 3 and then inhibits it. Therefore, it is called as an indirect inhibitor of factor 2A and factor 10A. Okay? And this, as it inhibits factor 2A and 10A, it usually inhibits the intrinsic pathway of coagulation, and therefore here the monitoring is done with APDT, because if the intrinsic pathway of coagulation is affected, APDT is usually prolonged in the patient. ठीक है? तो warfarin monitoring के लिए क्या यूज करते हो? PT या INR. Heparin monitoring के लिए APDT. No issues with this. याद रख लो. Heparin के मैंने बता दिया already. Low molecular weight heparin is nothing but enoxaparin or dietiparin. And these low molecular weight heparin mainly blocks. Heparin दोनों को block करता है, but low molecular weight है, so it mainly blocks factor 10A more than 2A. And if it is fondaparinux, only a fragment, if it is only fondaparinux, then it will only block factor 10A. Okay? That is the funda. No issues with this. These are the anticoagulants. So heparin is an injectable anticoagulant, therefore not given for a longer time. But what is the benefit or advantage of heparin? Heparin has fastest onset. Therefore, in emergencies, we need an anticoagulant. So, anticoagulant of choice in case of emergency, the answer should be heparin. Right? Warfarin is not given. Warfarin, first of all, is an oral drug, and second, it usually takes 4 to 5 days for a symptom for its action. Okay? Therefore, warfarin is not used in case of emergency. Second, heparin is also the anticoagulant of choice in cases of very good pregnancy. Heparin is also the anticoagulant of choice in cases of pregnancy. Warfarin is absolutely contraindicated during the first trimester of pregnancy. वैसे warfarin पे डालते हो तो patient को. Why? Because the reason being warfarin is an oral drug. Patient cannot get injections every day, right? That is the funda. Therefore, in first trimester of pregnancy and after 36 weeks, that is that term. Here definitely we will use heparin. But in between the second and third trimester, we can shift the patient to warfarin as well. ये ऑप्स में डिस्कस कर दिया है, ठीक है? Not let it. And if the patient comes to you, बता दो. If the patient comes to you with labor pain and she is already taking warfarin, what should be done? Continue warfarin and do which mode of delivery? Cesarean section. ठीक है, याद रखना. अगर पेशेंट वार्फारिन ले रही है और हमारे पास लेबर पेन में आती है, तब you need to continue warfarin in the patient and do a cesarean section. But if the patient comes to you without labor pain, वो 36 weeks पे आ गई, उसको labor pain अभी नहीं है, then what should be done? You need to stop warfarin and change over to heparin in the patient. Okay, that is the funda. ठीक है. And in warfarin toxicity, what is the drug? Vitamin K. warfarin तब ज्यादा हो जाता है. warfarin overdose अगर बोलूं मैं, ठीक है. If I talk about warfarin overdose, means when the warfarin is high and then this warfarin overdose, what can happen? There would be increased bleeding tendency. मतलब bleeding हो नहीं रही है. There are high chances of bleeding. Then the drug of choice in these two conditions is vitamin K, because it was blocking vitamin K. तो उल्टा दे दो, vitamin K दे दो. But if the patient is having bleeding due to warfarin toxicity, if the patient is having warfarin toxicity, bleeding, then here the answer will change to 4-factor complex. जो फैक्टर्स को इनहिबिट कर रहा था बस उतने ही फैक्टर्स दो. दैट इज व्हाट इज कॉल्ड एज फोर फैक्टर कॉम्प्लेक्स, also known as prothrombin factor complex. Okay, that is factor 2, 7, 9 and 10. This is the four factor complex which is available. अगर ये ऑप्शन में नहीं है, then you can go for the richest source of clotting factors, that is fresh frozen plasma. Even if that is not an option, you can go for whole blood. No issues with this, anybody? याद रखो. And what is the drug of choice for heparin toxicity? Protamine sulfate. Very good. कोई दिक्कत नहीं है अभी. प्रेगनेंसी भी समझ गए. फर्स्ट एंड ड्यूरिंग टर्म please give heparin. Second and third trimester you can put the patient on warfarin also. Why it is avoided during embryogenesis? Because it causes fetal warfarin syndrome or fetal hydantoin syndrome. तो उसमें usually क्या होता है? Microcephaly and nasal hypoplasia occurs due to warfarin. Moving further. Question number 34 now. A 65-year-old female with previous history of an ischemic stroke and myocardial infarction की भी history है. She is on treatment with a oral anticoagulant drug that is known as dabigatran. It inhibits which factor, anybody? Dabigatran 2A or very good. Thrombin. Thrombin is 2A. Factor 2 is called as thrombin. ठीक है? So indirect 2A and 10A inhibitor was heparin. Indirect 2A and 10A heparin. Indirect 2A and 10A heparin. Direct 2A inhibitors की अगर मैं बात करूं, most of them are injectable drugs like hepirudin or lepirudin. ठीक है, these are injectables. The only oral direct 2A inhibitor that is available is dabigatran in the patient. ठीक है, याद रख लो dabigatran. And वैसे ही direct 10A, indirect 2A and 10A heparin again. But direct 10A inhibitors की अगर मैं बात करूं, these are drugs like which contains 10A in their name. Very good. Rivaroxaban. 10A आ रहा है नाम में. Apixaban, Rivaroxaban. ठीक है, usually these are direct 10A inhibitors. If there is toxicity of dabigatran, usually what is the drug which we give? यहाँ पे भाई. So the patient was on treatment of dabigatran and aspirin. She is brought to emergency as she consumes many tablets of dabigatran. You are posted in casualty which among the following drugs will be used to reverse the effects of this drug. So they are not talking about they are talking about dabigatran toxicity. ठीक है, तो उसमें एंटीडोट दोगे और which is the antidote? Answer is a monoclonal antibody known as idarucizumab. Protamine sulfate is an antidote for heparin toxicity. Vitamin K is an antidote for warfarin. And andexanet alpha. Very good. It is an antidote usually for direct 10A inhibitors. That is rivaroxaban वगैरह. No issues with this, anybody? Shall I move further? Question number 35. A patient presents to the emergency room with palpitations, chest pain, breathlessness, and weakness in the limbs. Again, arrhythmia के features है ये. ठीक है, if the patient is having high heart rate, cardiac output कम हो जाएगा, and cardiac output जब कम हो जाएगा, patient will have usually features of breathlessness would be there. There would be weakness in all the limbs. ठीक है, chest pain भी हो सकता है due to decreased coronary flow. He has a history of coronary artery disease, that is a ischemic heart disease in the patient, and his blood pressure was 100/70 mm of Hg. That means the patient is stable. Heart rate is 90 beats per minute. Respiratory rate is 14 per minute. ECG is given below. What does the ECG suggest you of? Ventricular tachycardia, because here it is not a fibrillating wave. Rather, it is a broad QRS complexes which are seen, and broad QRS complexes are the feature of ventricular pathology. And here the heart rate is high. That means it is which ventricular pathology? Ventricular tachycardia. Stable or unstable? Stable VT. And I've already told you, if there is a patient with stable, that is hemodynamically stable ventricular tachycardia, we can go for chemical cardioversion. And this chemical cardioversion is done with the longest acting antiarrhythmic drug known as amiodarone. It is toxic to which organs? It is toxic to which organs? It is lungs. Because it causes pulmonary or lung fibrosis. It is also hepatotoxic. Okay, it will also lead to corneal deposits. It can even lead to hypo or hyperthyroidism. Okay, even it can cause myocardial depression. Okay, Newman syndrome भी हो सकता है इससे. ठीक है? No issues with this, anybody? Magnesium sulfate is usually given in which VT? Eclampsia में देते हैं, pre-eclampsia में नहीं, eclampsia. Pre-eclampsia में prevention के लिए दे सकते हो, but usually drug of choice है eclampsia. कौन सा? Very good. Torsades D-pointes. It is also a type of ventricular tachycardia. But इसमें क्या दिख रहा है? Here all the broad QRS complexes are of one size and one shape. This is what is called as a monomorphic VT. But if we can see, if there are something like this, okay, broad QRS complex. आप समझ लो, broad QRS complex with multiple size and shapes. That is what is a polymorphic VT. And in polymorphic VT, the drug of choice is magnesium sulfate. And this polymorphic VT is nothing but Torsades D-pointes caused due to QT prolongation. Yes, hypokalemia. No issues with this, anybody? समझ गए? अगर यहाँ patient का BP would have been somewhere around 70/40. The patient's BP would have been 70/40. Then your answer would have been DC cardioversion. कोई दिक्कत नहीं है इसमें. Question number 36. A patient had symptoms of redness and photophobia. On examination, cells were present in the anterior chamber with keratic precipitates. After हो चुकी है सबकी. Intraocular pressures was 30 mm of Hg. Which of the following anti-glaucoma drug should be avoided? पहले provisional diagnosis बताओ क्या है? Redness, photophobia, cells, keratic precipitates. Keratic precipitates are hallmark of anterior uveitis. Please remember. Okay. Along with that, definitely this uveitis can lead to cells or proteins inside the chamber, and this proteins or cells inside the anterior chamber can block the trabecular meshwork, and therefore the patient can have increased intraocular pressure. Okay, that is secondary to this. So it is a type of secondary glaucoma which has developed due to acute anterior uveitis. Okay, and acute anterior uveitis is an inflammatory condition. Therefore, the true drugs which will increase inflammation in this patient should be avoided. Inflammation is generally increased by prostaglandins. Therefore, any prostaglandin analog should be avoided in the patient. Along with that, the second drug which should be avoided is very good. कोई तो बोला, बोलो जोर से. Cholinergic drug like pilocarpine. That is also avoided in case of inflammatory conditions for glaucoma. Please remember. Okay. So to decrease IOP in inflammatory conditions, two drugs should never be given because they can increase inflammation and can worsen the condition of the patient. First are prostaglandin analogs and second are pilocarpine. Okay. And here the answer would be latanoprost, which is a prostaglandin analog. That should be avoided in this patient. So mannitol दे सकते हो, acetazolamide दे सकते हो, betaxolol. Betaxolol is avoided in which patients? Any beta blocker is usually avoided in asthmatic patients. But betaxolol is the only beta blocker which can be given in asthmatic patient because it is very selective. Okay, no issues with this. So अगर वो पूछते हैं which is the only beta blocker which can be given for glaucoma in an asthmatic patient, answer can be betaxolol. Okay, drug of choice for angle closure glaucoma. Drug of choice for angle closure glaucoma. Mannitol. Drug of choice for acute type of angle closure glaucoma. Pilocarpine. Drug of choice for open angle glaucoma. Latanoprost. That is a prostaglandin analog. Also you can use carboprost in the patient. कोई दिक्कत नहीं है इसमें, याद रख लो. But in pregnancy or children, which is the anti-glaucoma drug used? Apraclonidin or brimonidine. Okay, it is used in pregnancy or children for glaucoma. ठीक है? No issues with this, anybody? तो याद रख लो. Shall I move further? Question number 37. Glaucoma, again one of the important topics, not from pharma but from ophthalm too. ठीक है, तो glaucoma ढंग से पढ़ लो एक बारी. Comparative कर लेना. Open angle glaucoma, angle closure glaucoma. एक टेबल में दो साइड में लिख लो, easy हो जाता है. Question number 37. A patient was brought to the emergency department who was unconscious, non-responsive to pain and pinpoint pupils again. His respiratory rate is 10 per minute, मतलब decreased respiratory rate. That is respiratory depression हुआ है. His friends gives history of chronic substance abuse. कुछ ना कुछ खाता था ये. Which among the following drugs will not be responsible for his condition? So, yaad rakh lo, the respiratory rate is decreased. There are pinpoint pupils in the patient. Non-responsive to pain, that means param anand prapt kar raha hai. That is, he is having analgesia. Okay, and unconscious, that means he might be likely in coma or ya fir sedated a patient. ठीक है? And all of these are features of opioid overdose. All of these are features of opioid toxicity या opioid overdose. कोई दिक्कत नहीं है इसमें. So they can cause sedation. वो सेक्रम वाला फंडा सबको पता ही होगा. Okay, as for sedation, and अगर ज़्यादा हो जाता है तो कोमा में जाएगा patient. If for analgesia, that is why morphine or tramadol is used for pain relief in patient. C for constipation, therefore can be used in diarrhea. Drugs like पीली गोली जो खाते होंगे, non-infective diarrhea में देते हो, loperamide or diphenoxylate. These can be given only in non-infective diarrhea. अगर infective है, usually तो please give metrogel to the patient, metronidazole. R goes for respiratory depression, that causes decreased respiratory rate. U goes for बेवजह की खुशी, that is euphoria, and that is why it is addictive in nature. And M goes for meiosis of the pupils, that leads to pinpoint pupils. Pinpoint pupils का differential जो थे क्लास में पहले, organophosphate poisoning और organophosphate poisoning and opioid toxicity. ठीक है? Second, P goes for, very good, pontine hemorrhage, and second was very good, phenol, that is carbolic acid poisoning. So चार conditions में दिखता है pinpoint pupils. OP याद रखना है. O goes for OPC poisoning, and second O goes for opioid toxicity. P first goes for pontine hemorrhage, and second P goes for phenol, that is carbolic acid poisoning. आगे बढ़ते हैं. So usually, अरे इधर question है. So here opioid, which will act at all the three receptors, mu combined delta receptor agonist. These are drugs like morphine, which is used for analgesia. Okay, in cancer वगैरह. Any type of severe pain, morphine can be given to the patient except one. It is absolutely contraindicated in. Which type of pain? Very good. Biliary colic. It is absolutely contraindicated in biliary colic. So अगर pain हो रहा है due to biliary colic, then it should be absolutely contraindicated. Why? Because it will close the sphincter of Oddi, increase the risk of rupture of the bile duct, and therefore it is absolutely contraindicated. Morphine is also contraindicated in case of head injury. ठीक है? No issues with this anybody? तो कम से कम ये याद रख लेना. ठीक है? So here you can see morphine, heroin, tramadol, all of them are agonists of, okay, they will stimulate all the three receptors, but naloxone is rather a opioid antidote of poisoning, that is an opioid antagonist usually. ठीक है? It is an opioid antagonist, and therefore it is the drug of choice for opioid toxicity. So rather it will not lead to the condition, it will treat the condition. ठीक है? And what is the drug of choice? Drug of choice for opioid poisoning, naloxone, IV दिया जाता है. But for maintenance therapy, we need to give an oral drug. Answer is naltrexone. For de-addiction of opioid, we give a long-acting opioid known as. For de-addiction of opioid, बहुत लंबे टाइम से opioid खा रहा है. Methadone, long-acting opioid, which is known as methadone. This methadone is used for de-addiction of opioid, long-term de-addiction of opioid. ठीक है? And for relapse prevention, again you can give naltrexone to the patient. Question number 38. A 20-year-old female comes to the OPD with history of multiple episodes of nocturnal respiratory distress, classical funda, usually seen in winters. Due to cold exposure in winters, mainly during the night time, the patient is having respiratory distress. Younger female presenting to you. Condition subsides after taking inhaler. That means it is a reversible condition, bronchoconstriction. तीन characteristic features दिए हुए एग्जाम इसमें diagnosis के लिए बस यही तीन features चाहिए होता है. First of all, there should be reversible bronchoconstriction. The only reversible disease is asthma, bronchial asthma. ठीक है? Apart from that, it is mainly seen on cold air exposure, that is in the winter season, and mainly the episodes would be seen as the night time, nocturnal episodes. कोई दिक्कत नहीं है? आगे मैं आता हूँ. तब तक ये 3 फीचर्स एलर्जी की जरूरत नहीं होती डायग्नोज करने के लिए. ठीक है? तो ये 3 फीचर्स मेडिसिन के हिसाब से आर इनफ टू डायग्नोज आस्थमा. ठीक है? फैमिली हिस्ट्री ना हो या हो डिपेंड्स, क्योंकि फैमिली हिस्ट्री होगी तो वो यूजुअली चिल्ड्रन में होता है. ओके, फैमिली हिस्ट्री नहीं होगी तो अडल्ट का आस्थमा होता है. ये तो पढ़ा है. ठीक है? So now she gives history of allergic conditions in the family that further confirm that she is having atopy in the family, increasing the risk of bronchial asthma, allergic rhinitis, hay fever, and atopic dermatitis. ठीक है? Which among the following drug is required for maintenance therapy? Shabash. Inhaled fluticasone. Why? Because it is an inhaled corticosteroid. Drug of choice for maintenance of asthma are inhaled corticosteroids. Okay, याद रख लो. Inhaled corticosteroids. If for maintenance of asthma, if the patient is not only controlled with inhaled corticosteroids, then definitely we can add. Now, previously we used to add SABA, but now we don't add SABA. Now the recent recommendation says to add LABA, that is a long-acting beta-2 agonist. But salmeterol takes time to add, so we will take a faster agent like formoterol. Okay, LABA like formoterol would be added. No issues with this, anybody? So all of these are important. And if the patient presents to you with acute asthma, definitely you can give SABA to the patient. That is your short-acting beta-2 agonist like salbutamol, terbutaline. No issues with this, anybody? So please remember this. Okay? So I hope. And the question was in previous PG again. The question was a patient was on corticosteroid therapy. He was also given a long-acting beta-2 agonist, but still he is not showing improvement. What is the next drug to be added? Answer was the M3 blocker that is to be added, which is known as tiotropium or ipratropium, that is to be added in either format. Okay, so tiotropium or ipratropium is the third drug to be added after corticosteroid and LABA. Usually we will go for tiotropium or ipratropium, which is the M3 blocker. M3 receptors on the bronchus would be blocked, and as these M3 receptors are blocked, there will be bronchodilation. कोई दिक्कत नहीं है, याद रख लो. ठीक है? This theophylline is to be avoided with which other drug? Anybody? Theophylline is to be avoided with which another drug? Theophylline is actually metabolized by a microsomal enzyme. So if there is some drug which will lead to microsomal enzyme inhibition, that can cause toxicity of theophylline in the patient. ये तो पता है ना? If there are some microsomal, the enzymes which are present inside the endoplasmic reticulum are called as microsomal enzymes. Most of the drugs are usually metabolized by this microsomal enzyme. There are some drugs, okay, there are some drugs which can induce this microsomal enzyme. And if this microsomal enzymes are induced, the other drug will give. For example, if a patient was taking rifampicin for anti-tubercular therapy, and now he is given OCT. So what can happen? Usually OCTs are metabolized by this microsomal enzyme, and rifampicin is this enzyme inducer. If rifampicin is given, it will stimulate this microsomal enzyme, and that will rapidly metabolize the oral contraceptive pills. If the oral contraceptive pills are rapidly metabolized and thrown out of the body, then there would be failure of the drug. So enzyme inducers can cause failure of another drug. On the other hand, if there is an enzyme inhibitor, if it is given, the other drug will not be metabolized because these enzymes are inhibited, and therefore these drugs will keep on accumulating, causing toxicity of the drug. So yaad rakh lo, if we give enzyme inhibitor like erythromycin, this was the previous year question, isliye bata raha hu. Erythromycin, then theophylline can lead to toxicity because erythromycin is an enzyme inhibitor. Most of the antibiotics are enzyme inhibitors except rifampicin, which is an enzyme inducer. Most of the anti-epileptics are enzyme inducers except valproate, which is an enzyme inhibitor. कोई दिक्कत नहीं है? Moving further. Question number 39. A 30-year-old male patient presents with multiple petechiae all over the body, and there were bleeding episodes in the patient. He is having no history of infection or autoimmune disease. His CBC reveals low platelet count. मतलब CBC reveals low platelet count. मतलब thrombocytopenia. Which among the following drug will be prescribed to this patient to increase the platelet count? Diagnosis बता. कौन सा? चलो अपन ने लास्ट टाइम डिस्कस किया, इसलिए पूछ रहा हूँ. अडल्ट पेशेंट, ठीक है, याद आ जाएगा. अडल्ट पेशेंट, मल्टीपल पेटेकिए. तो अडल्ट पेशेंट, मल्टीपल पेटेकिए, there were bleeding episodes, no history of any infection or autoimmune disease. ठीक है, so that is a classical case of immune thrombocytopenic purpura. ठीक है, immune or idiopathic thrombocytopenic purpura. Idiopathic thrombocytopenic purpura are seen in adult, whereas in children there would be, in adults there is chronic ITP. In children we have acute ITP, and in children it is usually preceded by a history of viral infection usually. ठीक है, in adults there is no history of any viral infection. In children it is self-limiting, therefore no treatment is required. But in adults it needs treatment, like IV IGs can be given to the patient, and if not responding, plasmapheresis can be done. ठीक है, तो हेमाइट में कर लोगे, don't worry. ठीक है. So now here the patient was having chronic ITP. Okay, now there is low platelet count in this patient. So what should be given for low platelet count? We can give two drugs over here. Okay, सबसे पहले जो होती है to increase the platelet count, I'm saying not in this condition, but I'm saying to increase platelet count. मैंने दो drugs डाली थी options में. एक थी oprelvecin. First was oprelvecin and second was romiflostim. Oprelvecin stimulates the interleukin 11. We discussed interleukin 11 is the cytokine which is responsible for platelet production. So if interleukin 11 is stimulated, that can cause increased platelet production. So that is oprelvecin. But usually oprelvecin is used for thrombocytopenia caused by anti-cancer drugs. It is used for thrombocytopenia caused by anti-cancer drugs. Whereas romiflostim and second is L-thrombopag. इसके तो नाम में thrombo, इसलिए ये नहीं डाला. So romiflostim and L-thrombopag, usually these are used for thrombocytopenia, that is low platelet count due to ITP. No issues with this, anybody? And if there is leukopenia or neutropenia due to anti-cancer drugs, chemotherapy की वजह से, because it is suppressing the bone marrow, right? So there can be definitely neutropenia or leukopenia in this patient. So if there is only neutropenia, we will give a granulocyte colony stimulating factor that is called as filgrastim. This is the previous year question. ठीक है? You neutropenia में तुम क्या देते हो? You give a granulocyte colony stimulating factor like filgrastim. Gra मतलब only granulocytes are stimulated. Granulocyte stimulating factor. ठीक है? And sir, gramostim. It is when there is decreased levels of all the granulocytes as well as monocytes also. So this is a granulocyte monocyte colony stimulating factor. ठीक है? So granulocyte monocyte stimulating factor, that is SAR gramostin or mol gramostin. ठीक है? These are usually seen in anti-cancer drugs. जब तुम chemotherapy देते हो किसी patient को, the bone marrow of that patient is suppressed. One of the most common side effects of anti-cancer drugs. We have discussed already anti-cancer. ठीक है? तो उसमें usually there can be neutropenia or leukopenia which is seen. तो अगर बस neutropenia you can give filgrastim. अगर बहुत सारे और भी leukocytes are suppressed, then you can give SAR gramostin. अगर platelet count कम हो जाती है because megakaryocytes are suppressed, then you can give oprelvecin. And if there is ITP in the patient और उसकी वजह से low platelet count है, you can give either romiflostim or L-thrombopag. And definitely bone marrow suppression हो रहा है, leukocytes हो गए, platelets हो गए, और तीसरा क्या suppress होगा? Erythrocytes, that is RBC. So the patient can even suffer from anemia. So if the patient is taking anti-cancer drugs, the patient can even have anemia. So if the patient is having anemia due to chemotherapy or due to CKD, in both these conditions, the drug which is given is same, which will induce erythropoiesis, known as, very good, erythropoietin, and the recombinant erythropoietin that we have is known as darbepoetin. ठीक है? We will give darbepoetin. कोई दिक्कत नहीं है इसमें. ठीक है. Question number 40. Which among the following drug is used in osteoporosis inhibits the rank ligand? Answer is Romiflostim. ठीक है, ऑप्शन डी. क्या हुआ, लिखा तो था यार. अगर एंटी कैंसर की वजह से है तो ओपरेल्विक के, अगर आईटीपी की वजह से है तो रोमिफ्लॉस्टिम या एल्ट्रोम्बोपैक. Which among the following drug is used in osteoporosis which inhibits the rank ligand? Answer is straightforward. A monoclonal antibody which inhibits is denosumab. ठीक है. Infliximab is a TNF alpha inhibitor. ठीक है. And infliximab is given in which condition in adults? A young adult male with low backache, not responsive to steroids. Ankylosing spondylitis. ठीक है. तो ankylosing spondylitis के resistant cases में which is not responding to NSAID, the next drug that we give is infliximab. The other TNF alpha inhibitors are drugs like adalimumab, golimumab, etanercept. Okay, all of these. ठीक है. Teriparatide is what? It is a parathormone analog, and it is usually given in cases of CKD, chronic kidney disease, or in renal osteodystrophy, because in CKD there is decreased levels of vitamin D and therefore decreased levels of calcium and therefore osteoporosis. So CKD induced osteoporosis या renal osteodystrophy जो होती है उसमें तुम teriparatide यूज करते हो. That is low dose parathormone, because high dose parathormone will cause bone resorption. Low dose parathormone will cause bone formation because it will only activate osteoblasts and not osteoclasts. The drug for osteoporosis which activates both osteoblasts plus osteoclasts are this. नीचे दिख रही है बस खत्म. Low dose PTH और strontium ranilate. It is strontium ranilate. Trastuzumab is a which type of breast cancer? HER2 positive breast cancer, ER positive and PR positive, which is a hormonal breast cancer. Over there we can give drugs like, so that is selective estrogen receptor modulator like tamoxifen or raloxifene, and this is given in younger patient. Elderly patient may be given aromatase inhibitor drugs like anastrozole या letrozole. And अगर वो HER2 positive है then definitely we will give trastuzumab, or the second drug that is given anybody Herceptin. ठीक है, कोई दिक्कत नहीं है इसमें. Certolizumab और एक important monoclonal antibody है which is used in case of colorectal cancer. कोई दिक्कत नहीं है इसमें. तो एटलीस्ट कितने कम से कम एंटीबॉडीज, monoclonal antibodies याद रख लो. And omalizumab is a monoclonal antibody used for IgE, anti-IgE antibody used for asthma. ठीक है, तो asthma के लिए omalizumab यूज करते हो. ठीक है, तो with this thank you so much. Now but